We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 17 of AMOGS Emergency Obstetrics Committee with AP and Telangana, Vijayawada, Rajamandri, Mahabubnagar, Nalgonda OBGYN Societies. So let me introduce the MOC of today's webinars, Dr. Niharika Allu ma'am. Ma'am is the past secretary of Visakhapatnam OBGYN Society, consultant obstetrician and gynecologist, Birthright by Rainbow Hospitals, Visakhapatnam, executive member of Vaginal Surgeries Committee, FOXY 24 to 25, cell member of Publication Cell, FOXY 24 to 25. I welcome you, ma'am. And it's my privilege to introduce Dr. Sailaja Nalluri, ma'am. Ma'am is the Civil Surgeon Specialist, Insurance Medical Services, Vijayawada. Ma'am has been the past Treasurer and Secretary of Vijayawada OBGYN Society and also past Treasurer of Vijayawada Chapter of Indian Menopause Society. I welcome you, ma'am, and I hand over the session to you.
Yeah. Good evening, everyone. Thank you for joining this AMOGS Emergency Obstetrics Committee webinar with AP and Telangana Societies of Vijayawada, Mahabubnagar, Nalgonda, and Rajamandri. Dr. Snab Buar, madam, has been going on this webinar, and this is the 17th episode. I would like to introduce Dr. Snab Buar, madam. Sahiti, can I have the CV, please?
I think, Shailaja, we go ahead with the inauguration video first.
Inauguration, madam.
Yeah. Yes, yes.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya dipajyotirnamostute dipajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam.
Yeah. Dr. Snab Buar, madam, is from Yavatmal Society. Her education was in Pune, and after marriage, having shifted to Yavatmal, initially in government service for the first 5 years. Later, in government service, she has served the poor and needy people, being the active part of many NGOs, conducted many camps, free checkup and medicine distribution camps, continuing to update the skills of Asha and Anganwadi Sevikas. And for her work, Government of Maharashtra has felicitated her with Dr. Anandibai Joshi State Award in 2005. And for her professional excellence and continuous knowledge update and research, she has received the International MS Signature Award and Asia GCC Award and Lokmat Healthcare Excellence Award 2020. For her outstanding work in the field of rural obstetrics, FOXY has bestowed her with Dr. S.N. Malhotra Unsung Hero Award. She was the recipient of Champion of FOXY for 2 consecutive years and Dhira Award for the final year of her tenure as FOXY Chairperson Breast Committee. AMOGS has also recognized her work with Wonder AMOGSian and B-First 3 Award at Raj Bhavan, Mumbai at the hands of the Governor of Maharashtra. In 2023 AICOG, she was honored with the Individual National Award, Dr. Durusha Distinguished Community Service Award. She is contesting for Vice President FOXY West Zone for elections 24. I hand over to you, Snab Buar, madam.
Thank you so much, Dr. Shailaja, for that generous and kind introduction. At the outset, I would like to wish you a very good evening and a warm welcome to all of you. On behalf of the entire team of AMOGS, my dear friend, Dr. Kiran Kurtakoti, the President, Dr. Bipin Pandit, Secretary, and Dr. Rajendra Singh Pardesi, the immediate past President of AMOGS, and of course, Dr. Madhuri Mehnder as Treasurer, and Dr. Parag Biniwale as the National Coordinator, and myself, Dr. Snab Buar, as the Chairperson of Emergency Obstetrics Committee. So friends, my respect and regards to everyone, especially Dr. P.K. Shah sir, the past President of FOXY, Dr. Rishikesh Pai, sir, the immediate past President of FOXY as Chief Guest, and Dr. Aswit Kumar and Dr. Vidya Thobi, our dear friends, as guest of honor. A warm welcome to all of you. The long list of national and international awards is not, it's not received just recently, but since my 32 years of my experience has awarded me this. And definitely, I would like to serve the community as well as the organization in future also. So as breast committee chairperson, all of you know that we have worked on three aspects: the breastfeeding promotion, benign breast diseases, and of course the awareness and early detection of breast cancer. And for that, we have sensitized the Foxians by taking many CMEs, coming out with almost 4-5 e-newsletters, the update on bi-to-breast diseases, and there were many, training sessions also for the paramedics. For that, we have had training of trainers for almost 350 gynecologists all over India who trained the paramedics. And then, of course, the latest one was the Saheli, which was an initiative or the training module for the paramedics. Likewise, for AMOGS Medical Disorders Committee, we have collaborative programs for almost all the states and societies of India. And as AMOGS Emergency Committee Chairperson, we are continuing the same. Reducing the maternal, not only maternal, but maternal and perinatal mortality as well as morbidity. That is what is the mission, and we are just continuing to work for that. Today's topic and the speakers are very well chosen. Professor Dr. Sushila, who was the past president of Vijayawada Society, will be speaking on the second trimester pregnancy losses, the practice essentials. And of course, Professor Dr. Girija Wagh, the Vice President of FOXI, will be speaking on the stillbirth issues. I'll be moderating the panel on preterm labor as we top the list of, preterm birth, contributing to almost 3.5 million of the 11 million across the globe. And that is why I welcome all the faculties, chairperson, panelists, and delegates, whom I promise that it will be a very informative and useful practical session. I thank the president and secretaries of Vijayawada, Rajamundry, Mehboob Nagar, and Nalagunda societies. Just to name few faculties: Dr. Sridevi Velanki, Rajeshwari Praveen, Dr. Sudhir Babu Palli, and Dr. Aruna Suman, Aruna Kumari, Dr. Manjula Rapolo, Dr. Manjushri, Dr. Sushma, Dr. Satyashilpa and S.K. Shilpa, Dr. Devisri and Dr. V. Sarda, and of course my right and left, Dr. Niharika Allu and Dr. Sailaja. I welcome all of you and I thank all of you for your gracious presence. I welcome Dr. Rishikesh Pai, sir. I think I could see him just now. Once again, a very good evening to you, sir. And with this, I would like to invite my mentor, respected Dr. P.K. Shah, sir, for his words of guidance and blessings. All of you know, sir, as past president of FOXI, IAG, IFMB, and of course the dean of the Indian College of Medical Ultrasound, and sir has so many posts, already decorated, very highly decorated CV, I would say. But we are looking forward to you for your blessings, sir.
Yeah, thank you very much, Neha, for your kind words. First of all, let me thank AMOGS, the office bearers, Dr. Kiran Purtukoti, Dr. Rajendra Singh Pardesi, Dr. Vipin Pandit for this webinar, and the main person who is behind these webinars, Dr. Snab Buar, whom I know for many years, a very hardworking, sincere person who has been working for last so many years to spread the knowledge of obstetrics and gynec amongst FOXI members. We need such people in FOXI. And I wish her all the very best and success for the Vice President's post of FOXI, which is coming up in few months' time. Sneha, you thoroughly impressed me, and I feel that if we have from each state 1 or 2 people like you, I think FOXI need not look back and try to find out people who can work, because you are a very hard worker and a very sincere worker. and we need people like you. So thank you very much for having me with you. It's nice to see Dr. Rishikesh Pai, with whom I am sharing this platform of chief guest, past president of FOXY, and also the guests of honor, Dr. Aswat Kumar and Dr. Vidya Thobi. So as Sneha said, there are very good topics which are going to be covered, including second trimester pregnancy loss by Dr. Sushila and stillbirth by Dr. Girija, and then she herself and Dr. Rekha Bharti Rajshekhar, they are going to conduct a panel discussion on preterm labor, which is again going to be a very important topic for all of us in practice. It's nice to see young Turks like Shailaja and Niharika doing work of moderator. I think they are all learning how to become somebody like Snab Buar. So all the best. Thank you very much, Sneha, for all your future activities and success for all your future endeavors. Thank you.
Thank you, sir. Thank you so much. Thank you so much for your words of guidance as well as blessings.
Pleasure.
May I now invite
Good
Dr.
evening, sir. Meanwhile, good evening, PK Shah, sir.
Hey, good evening, Girija. I can see, sir, I have already welcomed you, Dr. Rishikesh Pai, sir. Saiti, as all of you know, sir, just is the immediate past president of FOXY, such a vibrant year, and all of you know him by his yatra and the gender equality run and whatnot. So we are thoroughly impressed with your work, whatever you have done over the last year, sir. Definitely, we know you as a doyen in the field of IVF, and of course, you have headed so many organizations. But without wasting much time, I think reading in your sleep, we would like to listen to your precious words, sir. Over to you, Dr. Rishikesh Pai, sir.
Thank you, Shreya. I'm really grateful to you. You're, as Dr. PK Char said, you're an excellent worker and wish you the very best for your future endeavors. And I'm sure you will achieve them. And I would like to pay my respects to Dr. Kiran Kortokoti, the president of AMOGS, Dr. Bipin Pandit, Secretary General, Dr. Rajendra Singh Pardesi, who is there, who is my very good friend, and also the immediate past president, Dr. Madhuri Mendle. And then, of course, Dr. PK Shah, I was his secretary in MOGS, and I always look up to sir, and he's been a great president. And then our guest of honor, Dr. Aswat Kumar, who is a fantastic person, dynamic, and Dr. Vidya Thobi, who is also, I wish her the very best for all her endeavors in the future. And there are a lot of important people like Dr. Susila, who is the past president of the Vijayawada Society. Thank you very much, madam. You have been a fantastic help to me, and when the yatra was there, and Dr. Sri Devi, who is the present president of Vijayawada Society, Dr. Rajeshwari Praveen, the secretary of the Nalgonda Society, Dr. Palil Sudhir Babu, who is a professor in Mahbub Nagar, and then we also have other people, our great vice president, Dr. Girija Wagh, a dynamic lady, and I don't have to say anything about her. She's been a trendsetter, and then we have got Aruna Suman, Aruna Kumari, then Dr. Manjula Gunendan, who is the president of the Nalgoda Society, Bharti Rajshekhar, who is the president of the Kasoga, again another dynamic person, and wish you the very best, Bharti, for your future endeavors. And then there are a lot of other consultants. Dr. Niharika is there, and Dr. Salaja, who are actually convening this program. And I would like to also recognize Dr. Satya, Dr. Sarda, Dr. Sushma, Dr. Devsiri, Dr. Shilpa, and Dr. Manjusri. So there's been a host of all. The Vijayawada is in. Chandrababu Naidu is in full force at present. As we are concerned, he is the kingmaker now of the whole next 5 years. And so we suddenly look at Andhra Pradesh with a great deal of respect, which has already been there. And I would like to not take much of your time, only that as the scientific chair of the All India, on behalf of Nandita Palchekar, who is the chair, Secretary General, Dr. Niranjan, and all our vice chairs, Dr. Rishma, Dr. Nozer, Dr. Suvarna, and Dr. Jaydeep Tang, who is also our president, and all our secretary, all our, see, in order to make the All India committee for the All India conference was very tough. Believe me, because all of them are big shots. So anyway, So I would like to invite you all. I was just sitting just now only. We are doing the program, and it's a tough thing, to have to arrange all. So I would like to request all of you important people of your society. We should not miss out on them. Maybe we'll make them chairs or whatever, but there's all the president, the president elects. So we have 277 societies. We have to take care of all of them. So it's a massive program. It's not an easy task. Plus, we have got nearly 140 foreigners are coming from all over the world. So from all the 5 continents. So let us hope that everything goes well. And only thing it will go well if all of you come for the conference. Only my problem is that if I go more than 10,000 people, I will be having a problem. So I may have to stop at 10,000. So I would like you all to please register early. Because everyone is carrying me saying there'll be 15,000 people, I can't handle that. So it's going to be difficult for me to, if I were to do a good conference, so please register early. And the rooms, we have taken 2,000 rooms, but I'm sure that a lot of you have got friends, family in Mumbai, so you'll stay there. But the nearby hotels and all we are taken, but once they are finished. So please start registering quickly for the conference, and it's going to be once in a lifetime conference. Let me tell you, the 2013 conference that did was also quite a massive. That time 12,000 people had come for the conference, and we had 17 film stars that time. So this time also we will go for a ultimate performance in the conference, and it will be only be successful if you come. So thank you, Sneha, for calling me here, and wish you the very best. I'm sure that you will achieve your goals. All the best.
Thank you, sir. Thank you so much. Thank you so much for your best wishes and your guidance as well. So, thanking all of you. And of course, I invite guest of honor, Dr. Ashwath Kumar, first. Dr. Vidya Thobe is traveling. So, Dr. Ashwath Kumar, we will have first, and then Dr. Rajendra Singh Pardesi as we host AMOGS and host this webinar. So, Dr. Ashwath Kumar was a past vice president with whom we have worked as chairperson. And of course, yes, Ashwath, I'm not going to say much. Everybody knows you. Everybody knows you so well. So, Saiti, you can stop.
No problem, madam. No need to have the CV. Anyway, madam, first of all, I thank Snab Buar, madam, for inviting me as a guest of honor among the greats, actually. PK Shah sir, Rishikesh Bhai sir, both are my mentors in Foxy. When I say PK Shah sir and all, without PK Shah sir, I would have never come into Foxy at all. Sir is one person who has encouraged me to come to Foxy, and I reached up to the vice president post. And Rishikesh Bhai sir always my mentor in many things, and I always look up to these two people as in Foxy. Both were when they were secretaries at that time, the Foxy was at its best, you can say, and their administrative powers and other techniques are all we learned through it. So thank you, madam, for inviting me to be a guest of honor with PK Shah sir and Rishikesh Bhai sir as chief guest, and Vidya Thobe madam from South, my friend. We moved together, and my madam is always like my friend, and such a nice person. So. And Pardesi sir is, we were vice presidents together. We have worked a long way, many projects we have worked together. Thank you, AMOGS. Thank you, Kiran Kote sir, Bipin Pandit sir, and all the members of AP Telangana. I cannot take all the names, but all of you are known to me. Vijayawada, Rajamundry, Mahabubnagar, Nalkonda, OBGYN Societies, everybody from all AP Telangana. First of all, Neha Buar madam, it's a wonderful program, actually, this on obstetrics, and we have topics like second trimester pregnancy loss, we have stillbirth, all, and a panel discussion on Snab Buar madam itself on preterm, and all these topics are very relevant. I'm not standing in between the CME and So thank you, madam, and thank you. All the best. Thank you and all the best, Ms. Neha, madam, for your vice president election. I am sure that you will win the election. And as Pikesh has rightly told, madam is such a sincere person. I have seen one of very few people who are very sincere to their work and never look upon posts or whatever it is. She works very sincerely and very friendly to everybody. And so we want such people in Foxy to climb up the ladder and future become the now vice president and future become the president of Foxy. So all the best, Neha madam, Sneha madam, for your election, and thank you once again for inviting me.
Thank you so much, Dr.
Thank you.
Thank you for your precious words. And Shailaja, may I request you to invite Dr. Vidya if she's there. You can just introduce her. She will join soon. And then
ma'am. Dr. Vidya Thobi is a professor and former head of the Department of OBG at Amin Medical College, Vijayapur, Karnataka. She is the present president of KSOGA, State Advisory PCB Entity Board, Karnataka member, chairperson Food, Drugs and Medical Surgical Equipment Committee, Foxy 2018 to 2020, and won the Best Committee Award, Dr. Mehrab Dara Hansotia in 2020. She has a list of awards, and she has been the National Corresponding Editor, Jogi, Organizing Chairperson for KSOGA 2016, has been the President of and Secretary of Bijapur OBGYN Society, has several publications to her credit, and this year she is contesting for the Vice President, South Zone, Foxy. Welcome, Vidya Thobi, madam. And I don't think she has joined, madam.
She is in the flight right now, but she will join soon. So no worries. We thank all of you. And of course, now the host, our immediate past president of AMOGS, my mentor in AMOGS and Foxy as well, Dr. Rajendra Singh Pardesi. Sir, can we have your precious words? All of you know you very well, sir. He's the immediate past president of AMOGS, and he was a past committee chairperson of Food and Drug Committee with so many, almost 28 papers and publications. So over to you, sir.
Good evening, everybody. Respected chief guest, Dr. P.K. Shah, sir, Dr. Hrishikesh Pai, sir, guest of honor, Dr. Ashwath Kumar, Dr. Vidya Thobi, Dr. Kiran Kurtakoti, our president, Dr. Bipin Pandit, then Dr. Girija Wag ma'am, Dr. Bharti Rajshekar Kasoga, president. So I am feeling proud and honored to be a part of this event, that with the presence of great personalities as chief guest, Dr. P.K. Shah sir and Dr. Hrishikesh Pai sir, who are hardcore Foxians, and due to them only Foxy is on the top. First, I wish to congratulate Dr. Snab Buar for organizing this webinar jointly with AP and Telangana Societies. As there is common things in AP, Telangana and AMOGS, these three societies, and with even Ashwath. So they are very much in bringing down maternal mortality rate. Even Maharashtra, we are having maternal mortality rate of 33, and Telangana AP, they are also maternal mortality rate below 45. So with this association, we can bring down it to single digit. So congratulations again to Dr. Sneha Buar. She is doing really excellent work. With the galaxy of speakers like Dr. Girija, Dr. Sushila from Vijayawada, Dr. Sneha, chairperson and panelists, I think this is going to be a great event. I wish every success to Dr. Sneha Buar for her future endeavor in Foxy. As Vice President Foxy in forthcoming election, I see Dr. Aruna Suman is there. I wish every success to Dr. Aruna Suman and Dr. Bharti Rajshekar for their future endeavor in Foxy as chairperson.
Thank you, sir.
Every success. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much. And I just take this opportunity to express my gratitude to all the stalwarts who have joined and blessed us and this program as well. So respected Dr. P.K. Shah sir, Dr. Hrishikesh Pai sir, Dr. Rajendra Singh Pardesi sir, and of course Dr. Ashwath Kumar and Dr. Vidya Thobi, who will be joining soon. All the faculty, especially Dr. Sushila, who is logged in right from the beginning, and Dr. Girija Wag, my dear friend, all the panelists, chairpersons, I have already welcomed you. I thank all of you for your gracious presence. And without much ado, we would like to go ahead with the academic session. And I would like to hand over to Dr. Niharika and Dr. Shailaja. Thank you so much once again. And I just make an humble appeal that I'm contesting for Vice President Foxy from West Zone for the upcoming elections. So not only your vote, but I request the votes from your society members, friends and colleagues and alumni. Please do support me from wherever possible. Thank you so much.
Thank you, madam. Sahiti, can we have the CVs of the chairpersons of the first session? We are starting with second trimester pregnancy loss practice essentials. Our speaker will be Dr. Susila, past president Vijayawada Society. And our chairpersons are Dr. Vellanki Sridevi, the present president Vijayawada Society. She has been the vice president of WOGS previously, worked as past secretary WOGS, the first lady honorary secretary IMA Vijayawada and vice president IMA Vijayawada. She has been in part of organizing APCOG 2006 and was the founder secretary of APOGS formed after AP bifurcation. She has been the organizing secretary of Platinum Jubilee celebrations of IMA Vijayawada in 2013 and faculty at various CMEs and conferences. Next CV Sahiti. Dr. Rajeshwari Praveen is the secretary Nalgonda Society. She has been the best outgoing student at Vijayanagar Institute of Medical Sciences and completing her MS at the prestigious Grand Medical College and JJ Hospital, Mumbai in 2009. She served as medical college faculty before transitioning to her current role as consultant obstetrician and gynecologist with special interest in infertility at Rajeshwari Hospital, Nalgonda. Welcome, Dr. Rajeshwari.
Thank
Dr.
you.
Sudhir Babu, Professor and HOD OBGYN, SVSMC Mehboob Nagar, ex-Dean at RIMS Raipur and ex-MCA Inspector and NMC Assessor for DNB. Welcome, Sudhir Babu, sir. I hand over to Dr. Rajeshwari to introduce our speaker for this first session, please.
Good evening, all. So it's my pleasure to introduce Dr. Sushila Madam. She is the consultant of Lata Super Speciality Hospital, Vijayawada. And Madam's major achievements are, as we come to know, like she was the past president of Vijayawada OBGYN Society 22-23. And she was secretary for Vijayawada Menopause Society from 2018 to 23. Organizing secretary first APCOG 2015 and UA Foxy 2018. And she has delivered the prestigious Foxy ICOG Dr. C.L. Javeri Endowment Symposium at Kolkata. And she delivered the IMA AP State Dr. Gurumurthy Memorial Oration 23. And Madam was awarded with Foxy Achievers Award 2023. She was a speaker at national conferences and she has authored the chapters and articles in various books. Madam, it's over to you, Madam. Thank you.
Thank you, Dr. Rajeshwari, for the kind introduction. So thank you, Dr. Sneha Madam, for the opportunity. So Shailaja, are you able to see my screen?
Yes, madam, we can see the screen. Just make it full screen.
Yeah, I'll just make it. Thank you, Dr. PK sir, and all the seniors, AMOGS office bearers of the Vijayawada Society, Mehboob Nagar, Nalgonda, and also Rajamandry Society, Dr. Girijawag, Dr. Bharati Rajshekar, the panelists, and the delegates who have logged in. So thank you so much. And I'll be talking about the second trimester pregnancy loss, the practice essentials in the next 15 minutes. So how do we define the second trimester pregnancy loss? And it is the miscarriage that is diagnosed between the duration of 13 to 24 weeks of gestation. And the incidence is about 0.5% in low risk group, and it is more in case of the high risk group. And it is an unanticipated and an unexpected event for the couple, which causes physical and emotional and traumatic burden. And also it is very unpleasant to the physician too. And coming to the etiology, the maternal factors include the anatomical factors, the immunological factors, infection, placental problems, severe acute illness, thrombophilias, and uncontrolled chronic illnesses. So the anatomic factors include the incompetent cervix, intrauterine adhesions, leiomyomata, and uterine anomalies. The immunological factors constitutes the antiphospholipid antibody syndrome, and the infections may be like bacterial vaginosis or the chorioamnionitis. And the placental problems can be like due to the retained intrauterine devices or the placental abruption or the low-lying placenta. And the thrombophilias may be due to the proteinase deficiency or protein C deficiency or factor V laden. And the uncontrolled chronic illnesses may be in the form of the diabetes and hypertension. The other part is the fetal factors like chromosomal abnormalities and congenital abnormalities. The second trimester fetal losses can also be due to drug use, also due to the smoking, teratogenic exposure, and trauma, that is the physical abuse. So the chromosomal abnormalities, we usually have a notion that it is usually that it causes the first trimester loss, but around 24% of the pregnancy losses in the second trimester are due to the abnormalities in the chromosome, and more so it is during the 20 to 24 weeks of pregnancy loss. And mainly it is the aneuploidy, like in the first trimester, and along with the duplications and deletion of the chromosomes. And around 30 abnormalities have been detected which causes second trimester abortions, and about 11 chromosomes defects have been found. The most frequent, the karyotype which causes the second trimester fetal loss is the trisomy 18, followed by monosomy X, trisomy 21, and the trisomy 13. And the detection rate is mainly by the next generation gene sequencing. It is much superior than the FISH technique, and it helps to offer the genetic counseling to the couple, wherein the diagnosis of which chromosome and which whether it is going to be transmitted or how it is going to affect the next pregnancy would be the genetic counselor can help them in diagnosing the chromosomal abnormality. So basically, the genetic counseling is done when the couple has a problem with the chromosomes or the abortus is found to have a chromosomal abnormality. So the magnitude of the risk of various chromosomal abnormalities can be discussed. The risk of miscarriages can be discussed with the couple, and also whether they're going to have a fetus with a chromosomally normal or an abnormal conceptus, and their ratios can be put forward by the genetic counselor to the couple, wherein they can decide. And the couples with the karyotypic abnormalities can go for prenatal genetic studies like amniocentesis or the chorionis willis sampling, and in case if the fetus is affected, can go for pregnancy termination. The other options would be the in vitro fertilization with pre-implantation genetic testing, wherein the problem of any chromosomal defect can be diagnosed. And if any problem is there or any chromosomal abnormality is there, they could go for a termination. And the other options can be the gamete donation or a surrogacy or an adoption. All these prevent the conceptus of being an affected embryo. And the fetal anatomical factors, that is the structural abnormalities, could be due to the maternal medical conditions like uncontrolled maternal diabetes at the conception, and also may be due to the hypertension. The structural abnormalities could be due to the drugs, environmental chemicals, amniotic band syndrome, maternal exposure to teratogen, and physical stress like fever. And the maternal anatomic factors, that could be the congenital or the acquired uterine anomalies. The congenital uterine anomalies constitute about 7 to 28% of the second trimester pregnancy losses. Mainly it is due to the septate uterus, about 6 to 16%, and a minor proportion is due to the unicornuate, arcuate, and the bicornuate uterus. The acquired uterine anomalies, which constitutes about 6 to 15% of pregnancy loss, is due to the cervical insufficiency, submucosal myomas, intrauterine adhesions, and the endometrium polyps. Sorry. And 3 to 4% is due to the intrauterine adhesions, but is comparatively the studies show much less, but it would be more, causing the second trimester pregnancy losses, mainly due to the denuded endometrium or insufficient vascularization. So the retained products of conception, whether it is a medical method of abortion or the surgical or a spontaneous abortion, all this contribute to the intrauterine adhesions. At the same time, surgical procedures like hysteroscopic myomectomies, metroplasties, all these also may cause intrauterine adhesions. So there is a controversial study which has been done in 2019 saying that the uterine leiomyomas are not associated with the increased risk of abortions, but many of these studies indicate that they are one of the reasons for the second trimester abortions. And the management of the Mullerian, coming to the management of these anatomical defects, it would be like the Mullerian anomalies, surgical correction would be controversial, but the key evidence says that the hysteroscopic metroplasty for septate uterus gives a good favorable outcome of pregnancy. And along with GnRH analog and temporary IUCD, there is definitely an improvement in the reproductive outcome, which constitutes about 80% of prevention of the second trimester abortions. The intrauterine adhesions can be tackled with hysteroscopic division and temporary intrauterine device and postoperative course of cyclic estrogens and progesterones. And mainly the submucous fibromyomas can be tackled with hysteroscopic myomectomy along with the GnRH analogs. And this is one of the paper which says that the reduction of the miscarriage rate from 41% of the pre-myomectomy to 19% to the post-myomectomy has been reported. And the myomectomy should be considered in a woman with a history of pregnancy loss, especially the mid-trimester loss or 2 first trimester losses. So this gives a good reproductive outcome. And coming to the cervical insufficiency or incompetence, so it is usually seen in the mid-trimester, and the patient complains of the pelvic pressure, Braxton Hicks-like contractions, or a premenstrual like cramping, backache, or change in the vaginal discharge. The volume of the vaginal discharge increases. The color may change from clear to white or light yellow to pink or spotting. And the consistency may also become thinner. And after the painless cervical dilatation, that is, patient does not have any pain, typically the membranes balloon into the vagina, followed by a rupture of the membranes and expulsion of the fetus. So, and then sometimes it may also be asymptomatic. So the symptoms begin typically between 14 to 20 weeks and may be present for several days or weeks before the diagnosis of cervical insufficiency is made. So it takes a few weeks for the progress from the shortening of the cervix, ballooning, rupture of the membranes, where we can diagnose with the physical examination or with an ultrasound. So the structural cervical weakness is likely cause of the cervical insufficiency and is secondary due to procedures like cone biopsy or a rapid mechanical dilatation or infection which causes biochemical changes. And a congenital cervical abnormality can be there, which is very rarely seen. And the diagnosis is by history, that is 1 or more, 2 or more second trimester abortions or a preterm labor, or in combination with the transvaginal ultrasound measurements of the cervical length or a physical examination wherein there is an advanced cervical dilatation. So in a singleton pregnancy, coming to the management, in a singleton pregnancy, usually a single measurement of cervical length at 20 weeks is sufficient, which should be more than 2.5 centimeters. If it is more than 2.5 centimeters, routine prenatal care is followed. But if it is less than 2.5 centimeters, a vaginal progesterone suppository daily up till 36 weeks is advised. And if the cervical length is shorter than 1.5 centimeters, then a placement of the rescue cerclage is indicated. And in cases where there is a abortion between 14 to 27 weeks, the first measurement of the cervical length has to be started at 14 weeks. If it is more than 3 centimeters, every 2 weeks it has to be repeated, and as a rescue cerclage is placed when it is less than 2.5 centimeters. In case of a previous preterm birth, at 16 weeks we have to measure the cervical length, and if it is like between 2.6 to 2.9 centimeters, a repeat measurement is done weekly. And if it is less than 2.5 centimeters, then a rescue cerclage is indicated. So it is 20 weeks in a singleton pregnancy without any prior history. With a prior history of mid-trimester loss, it is at 14 weeks. In a case of preterm labor, the first measurement has to be done at 16 weeks and followed up. And in subsequent pregnancies, with a successful history indicated, that is, the woman has a preterm labor or a previous mid-trimester abortion, the cerclage has to be done at 12 to 14 weeks of gestation. If it fails in the next pregnancy, in the inter-pregnancy trans-abdominal laparoscopic cervicoischemic cerclage is done in case if a history indicated cervical and cerclage fails. And with a successful ultrasound indicated, that is when we monitor the cervical length and the delivery is after 34 weeks. In the subsequent pregnancy, the ultrasound indicated cerclage is done if it is less than 2.5 centimeters before 24 weeks. There is no role of cerclage after 24 weeks of gestation. If the previous ultrasound indicated cerclage was unsuccessful, that is, we are measuring the cervical length, and then we have put a cerclage, and the pregnancy has gone up to 34 weeks. It is okay. We again monitor. But if it is less, if the woman has delivered before 34 weeks, we need to go for a history indicated cerclage at 12 to 14 weeks of gestation. If the history indicated cerclage fails, we need to go for a trans-abdominal or laparoscopic cervicoischemic cerclage. And in a patient where the physical examination is done and there is a dilatation, we need to go for a rescue cerclage. And in the next pregnancy, we have to follow with the transvaginal ultrasound. And whenever there is a shortening, we have to go for a rescue cerclage. So mainly the history indicated, then it is the ultrasound indicated, then it is a physical examination indicated. And in case of the infection, 10 to 25% of the second trimester pregnancy losses are due to the infections caused by either bacteria or protozoa or virus or the fungus. Mainly it is seen in the developing countries, and the bacterial vaginosis is increased in second trimester losses as we see in the preterm births. And the intrauterine infections are more common in the second trimester, probably because of the increase in the fetal inflammatory responses, and also as the fetal immune response matures. So it decreases during the third trimester and it is quite less in the first trimester. And the chorioamnitis, there are 4 stages where there is a change in the vaginal or cervical microbiome, followed by access to the amniotic cavity and entry into the amniotic cavity causing the intraamniotic infection, and 4th stage is where the fetus is also affected. So the samples and the tests that we do are the blood test, the amniotic fluid via the transabdominal amniocentesis, and culture, gram stain is done, and also the glucose test is done, and histological examination after the expulsion. And the chorioamnitis the clinical manifestations would be like the preterm rupture of membranes or a preterm labor with fever more than 100 degrees Fahrenheit, or a maternal leukocytosis, maternal tachycardia, fetal tachycardia, uterine tenderness, bacteremia, or a purulent malodorous amniotic fluid. In all these cases, the antibiotics have to be started, and irrespective of the gestational age, we need to go for the delivery. And in case of the inherited thrombophilias, it is the factor 5 protein S, protein C deficiencies, and also the prothrombin gene mutations, which constitute about 20 to 24, which constitutes about quite a number. that has been done by a meta-analysis in 31 studies and more common between 20 to 24 weeks of gestation. The other important aspect is antiphospholipid antibody syndrome, which is immunological disorder wherein the lupus anticoagulant and anti-cardiolipin antibodies are positive, and it can be in isolation or it is associated with systemic lupus erythematosus or other autoimmune disorders like Sjogren's syndrome. These antibodies cause the placental thrombosis, and it has been well established to cause the second trimester fetal loss, and combination therapy of heparin and aspirin decreases the second trimester losses by about 54%. And heparin alone is used in cases of thrombophilias and decreases about 50 to 70% of the second trimester losses. So mainly the antepartum prophylactic dose of low molecular weight heparin along with the aspirin is used in the antiphospholipid antibody syndrome. And a therapeutic dose has to be used in case of the arterial or venous thrombosis. Otherwise, it is only the prophylactic dose, which constitutes about 1 milligram per kg body weight every 12 hours is the therapeutic dose of enoxaparin. And it is 40 milligrams subcutaneously once a day, which is the prophylactic dose. And we all know that multiple pregnancies are in rise due to the IVF, and more fetal losses have been documented, mainly 14.12% in monochorionic twins and 2.6% of fetal losses for the dichorionic twins. So this is an interesting paper which says that high incidence of second trimester pregnancy losses have been included due to the tuboperitoneal infertility, multiple gestation, high order multiple gestations, and there is the fetal of second trimester fetal losses have not been documented or increased with chorionis villus sampling or the amniocentesis, and also with age. So there is no relation between the age and second trimester fetal losses in IVF pregnancies, and also and chorionis villus sampling or amniocentesis have not been increased, and also the multiple fetal reductions have also not been increased with the second trimester abortions. And how do we assess the patient and do the follow-up? First important thing is the thorough history and physical examination. That is, the history should include the symptoms, and we have to take history of the chronic maternal medical conditions, family history, which can suggest the genetic problems, medications use, which can also cause the fetal loss, environmental exposure, substance abuse, trauma, and obstetric history in detail. In the clinical assessment, the patient may come with the vaginal bleeding, abdominal pain, ruptured membranes, vaginal discharge, feeling of pressure in vagina, may be associated with medical disorders like diabetes, history of any cervical surgeries, or history of the previous pregnancy loss, and none of the history may be helpful for the diagnosis. Examination is baseline vital signs have to be taken. Careful abdominal examination, including the height of the uterus, any tenderness, any contractions. Sterile speculum examination has to be done to see for the vaginal discharge, vaginal bleeding, liquor, any bag of membranes. And the gentle vaginal examination has to be done. But in case we are planning for a high vaginal swab, first the swab has to be taken, then followed by a examination. The key recommendations for the assessment of a patient who's in the process of the second trimester abortion, or there is a cervical or any other etiology of second trimester medical abortion, we have to take a detailed history. And vital signs, weight gain history is also be taken. Review the dating parameters, ultrasonography, and laboratory investigations. And a real-time ultrasonography has to be done by a trained ultrasonographer to diagnose the four-chamber view, that is whether the fetal cardiac activity is present or not. With the help of a Doppler, it would document. And the cervical length, ballooning of the cervix, liquor, volume, and placental site have to be noted on the assessment form. And the laboratory investigations to assess the maternal fetal well-being is very important. And what are the investigations that we need to do is complete blood picture, clotting screen, blood group, and antibody screen in case of Rh negative, and C-reactive protein. And the maternal coagulation profile is not needed unless there is a sepsis or a patient, the woman is with the preeclampsia, and the maternal microbiology is needed when there is an abnormal vaginal discharge, which includes the midstream urine analysis, vaginal and cervical swabs, and abnormal renal function test indicates Zappler syndrome, and abnormal liver function test can indicate viral hepatitis, cytomegalovirus virus infections, and toxoplasmosis, and also in the HELP syndrome. And women with the chorioamnionitis, we need to start on broad spectrum intravenous antibiotics without any delay, and we need to go for delivery. And the cord, the membranes, and the placenta should be retained for the pathological examination. And fetal cytogenetic analysis should be performed in all the cases. And the sampling of the placental tissue is very important. And supportive care has to be given to the couple. The standardized checklist has to be completed. And we also need to give them the follow-up appointment along with the investigation reports, where we need to assess. And selective investigations, like as I said, the antibody test has to be done, and also specific maternal infection screening can be done if a suspect infection. And in case of the substance abuse, we can also test for the maternal urine. And the fetal hydrops also indicates that there is a problem with the red cell antibody screen. And anti-Rho and anti-LA antibodies have to be screened. Thyroid function test and HbA1c has to be ordered for. And many a times the expectant management can work out, like more than 85% of women with intrauterine fetal death deliver within 3 weeks. And if the woman is physically well and there is a closed cervix and intact membranes, we can as well ask her to like not get admitted and be at home. And 10% of chances of maternal coagulopathy can be there after 4 weeks. We have to remember this. So we have to ask her to come back within 2 weeks. And medical management of the second trimester is has to be done in cases where there is bleeding and also the rupture of the membranes. The pre-induction protocol has to be followed, specifically when there is a scarred uterus. In almost all cases where the induction delivery interval decreases is with the mifepristone. And the mifepristone is given in 200 milligrams once, and after for 24 to 48 hours, the woman is asked to come back. And the misoprostol 200 milligrams 6 hourly for 4 doses in 13 to 18 weeks, and about 18 weeks 100 micrograms 6 hourly for 4 doses is inserted vaginally, and vaginal route is preferable as the side effects are very less. And then in case the expulsion has not occurred, the repeat course can be given after 12 hours. In case of the ruptured membranes, oxytocin infusion can be started. And in cases of the scarred uterus, we ought to be very careful when we are using the misoprostol. And all the staff have to be very vigilant. The vitals have to be recorded. And the indications of the rupture may be tachycardia, atypical pain, vaginal bleeding, hematuria, and maternal collapse. And retained placenta is one of the complications in all these inductions, which is about 21%. 10 units of intramuscular oxytocin has an expulsion rate of 90% within 60 minutes of administration. And if this fails, we can go for a carboprost 250 micrograms every 20 minutes for 3 doses, and misoprostol of 600 micrograms orally or 800 micrograms rectally, which is quite effective. And surgical removal is indicated when there is when the placenta is undelivered after 2 hours, and the informed written consent is taken whenever we go for a surgical evacuation. And vaginal birth is recommended. So we should not go for a hysterectomy unless otherwise indicated, like where there is a deterioration of the maternal condition, or in cases of multiple previous cesarean sections and a morbidly adherent placenta. And there is no role of resuscitation within 23 or 24 weeks, because usually it is not a salvageable one. So when it is more than 24 weeks, we can go for a resuscitation. and we need to support the couple because of the depression, anxiety, and it is very difficult for them to share the second trimester fetal loss, because already they must have the good news of pregnancy sharing with their families, and it would be emotionally draining them. So psychological support is very important. And coming to the pathological examination, the comprehensive external examination of the baby has to be done. Macroscopic examination of the placenta and the cord is very important. And the placental swabs have to be taken in cases of infection. And the placental karyotyping also helps in diagnosis of any chromosomal abnormalities. And postpartum examination and the placental histology should be offered to all women who experience a second trimester miscarriage. And in case if the couple is not willing, at least the placental histology has to be done. And below 16 weeks, it is only the placental histology. There is no need to go for a postmortem of the fetus or the fetal autopsy. And thromboprophylaxis is as usual, but we need to be very careful when the woman is in DIC. And we have to know what are the clue points. That is it a recurrent one or is it the first one? That is, if it is recurrent one, maybe it is chromosomal abnormality. If the fetal malformations are there, is it due to the maternal illness or the like diabetes? And if it is a painless rupture of membranes, is it like it gives a clue of cervical insufficiency? In cases of unexplained loss, maybe it is the intrauterine adhesions or the Mullerian anomalies. In case of the placental abruption, it is antiphospholipid antibody syndrome. Or in case if the woman also has an autoimmune disease, probably it is the antiphospholipid antibody syndrome, which is the cause. And thrombophilias have also been excluded, like arterial or venous thrombosis history, where the stroke in young, etc., can be elicited from the mother, and the maternal infection. The clue can be like maternal fever, tenderness of the uterus, etc. So we should have a chart of all these clues where they would be helpful for us for the diagnosis. And the clinical recommendations are to improve the reproductive outcome: hysteroscopic metroplasty for septate uterus, cervical encerclage as per the guidelines, and combined unfractionated heparin and aspirin in cases of the antiphospholipid syndrome, and providing support and counseling, which is very important for the couple. And postnatal investigations, mainly we need to go for the cultures and also the chromosomal abnormalities. That is, the parental karyotyping is very important. And also in cases where we suspect thrombophilias, we need to go for the testing of the protein C and protein S deficiencies. And when we have maternal autoantibody testing, this is mainly for where the cause is not known. And whenever there is the antibodies, the lupus anticoagulant or anticardiolipin antibodies are positive, then we need to repeat it after 12 weeks after delivery for the confirmation. And in the follow-up visits, we have to assess the maternal recovery both physically and psychologically. Is she good? And at consultation, we need to have the results of the investigations. We need to evaluate what is the cause of the miscarriage, and pre-pregnancy plan has to be chalked out, like ask her to stop smoking, give her the folic acid advice, BMI optimization, and any psychological issues are there, we need to address them. Any medications, we need to stop or change the medications, have to be taken care of. And pre-pregnancy plan has to be given for the woman that is booked under a consultant obstetrician, with consider whether aspirin or low molecular weight heparin are indicated regarding the cervical length, and also the ultrasounds, whether we have to follow the cervical changes and other extra precautions. And also we need to tackle the psychological status. And unexplained pregnancy in cases where the karyotyping analysis has to be done, which is very important, where we do not have any diagnosis. And other important thing is, women this second trimester pregnancy loss are at significant increase of spontaneous preterm births and also recurrent second trimester pregnancy loss. which we need to inform the couple whenever they come for the next pregnancy. That is, they may land in the preterm birth or the recurrent second trimester loss. And 39% of the women have a preterm delivery, 5% have stillbirths, 6% have a neonatal deaths. And another important thing is they may have the obstetric issues like fetal growth restriction. And the marker of future maternal health, this is one of the marker to say where recurrent abortions or the second trimester abortion would mean that the mother may land in premature death too, because of the antiphospholipid antibody or immunological disorders or autoimmune disorders or the chromosomal abnormalities. She may have a premature death. So we need to address the psychological support mainly in the next pregnancy where she's she has anxiety, and also she's overprotective of the child after birth, and we need to address all the psychological issues and support the couple. So the take-home points are we need to know what are the etiologies. That is the I see what the mind knows. So we should know all the each and every etiological points and also the treatment aspects. And we need to take the help of the clues to arrive at the diagnosis. The investigation should be thorough. That is the placental pathology and the autopsies and also next generation sequencing. All these are very important and manage as per the guidelines. And we should also categorize whether the cause is a recurrent one or a non-recurrent one. And we cannot overtreat. That is specifically in a case of intrauterine additions, where we overtreat it again. Again, the patient lands up with the pregnancy losses. Again, we go for a curettage. Again, there are the intrauterine additions. So we have to be very cautious, not overtreating the patient, and treat every index case, that is a first, second trimester pregnancy loss, as a recurrent pregnancy loss case. So this makes us very cautious. And also we need to have the checklist where we ought to fill each and everything, not to miss the etiology, not to miss them, to go for the investigations to arrive at a proper diagnosis and treatment. Thank you so much. Thank you, Dr. Sneha, for giving me the opportunity. Thank you so much, madam.
Yeah,
Thank you, Susila madam. Sneha madam, you want to say something?
No, I just wanted to thank you indeed. It is our pleasure to have you, and it was a very informative, very elaborate talk, I would say. And I would like to have the chairperson's comments on this. Thank you.
Good evening, everybody. That was an excellent and extensive presentation by Dr. Susila with very useful flowcharts for practice for obstetricians. And as you said, the recognition of the causative factors and proper diagnosis is the key to is the key for dealing these cases. Very nice presentation. What about Arabian pessary? Do you have any?
Actually, Dr. Sridevi, Arabian pessary has not been accepted in most of the studies. So it has been FDA approved, but still not much of the studies, and most of the studies like up-to-date ACOG, they have not authenticated its use.
Okay, thank you. Then, Madam Snab Buar, there's a program called CLEAR, which is a cervical length education and review program by the Society for Maternal and Fetal Medicine. This program is for certification of obstetricians and ultrasonologists. They extensively train them, and only those people can do the scan for diagnosing cervical incompetence, in addition to all the clinical factors that we see. Do you agree, ma'am? Is it essential? And should it be in the training of our PGs?
Definitely. I think we should take this in our agenda to discuss and go ahead how we have been, talking. As a breast committee chairperson, I have proposed that the study of breast should be as a part of the postgraduate curriculum. Similarly, I think all of you will agree to me also that obstetrician is the best sonologist if you are trained enough and adequately and in the proper manner. So as you are saying rightly that there is a certification course, and if the obstetrician is well trained with this, definitely it's going to be the best possible sonography, I would say, and I think it should be included as a part of the curriculum. So
Thank
we
you,
should
ma'am.
definitely take this ahead.
Thank you, ma'am, for giving us this opportunity. I would like to invite the comments of my co-chairperson and wish you all the best, ma'am.
Thank you. Thank you so much.
Good evening, everyone.
Good evening,
And
sir.
And I highly appreciate Speaker Madam Dr. Sushila for clear and concise and a very simple presentation, easily understandable, and it was a very with a very good flow and easily understandable for everyone. And she has covered everything. And I would like to agree with her regarding the identification and removal of myomas, which gives a very good outcomes in case of RPL. And I would like to add a note for the young people who have joined here, not to forget to give a stress on the psychological aspects of the couple who are involved in RPL, and as well as lifestyle modifications, and not to forget the BMI as in this one. And thank you, Madam Sailaja Nalluri Madam, and Niharika Allu Madam, and especially Dr. Sailaja Nalluri Madam, and Snab Buar Madam. Madam, all the best, madam, and good luck, and we will be with you, madam.
It is our pleasure to have you and your precious words. Thank you so much for gracing the program and your valuable inputs. Thank you.
Thank you so much, Dr. Sneha Madam. It was pleasure to be a part of this CME, and also all the very best for you for the upcoming elections, madam.
Thank you, madam. Thank you so much.
Thank you, Susila madam. And I thank my chairpersons, Dr. Rajeswari, Dr. Sudhir Babu, and Dr. Sridevi madam, our president. I hand over to Dr. Niharika for our next session. We can't hear you, Niharika.
Yeah. Thank you, Dr. Shelja. Good evening, everybody. It's a pleasure to be on this platform. So it's a privilege to be introducing the chairpersons for the second session. Dr. Aruna Suman, she's my teacher, and she's presently a professor and HOD at Government Medical College, Jagatyal in Telangana. We all know her for her great organizing skills at AICOG Hyderabad as the organizing secretary. She's also been the joint secretary for FOXY 2021. She's been a committee member in lot of committees, and madam is also contesting for the post of Practical Obstetrics Committee chairperson. So wish madam all the best, and welcome madam. Next, Dr. Aruna Kumari. She is graduated from Rangaraya Medical College, Kakinada, and her post-graduation is from PGI Chandigarh, and she's presently the president of the Rajahmundry Obstetrics and Gynec Society, and she's a senior consultant at Harsha Hospitals, Rajahmundry, and she's also attended many conferences. Dr. Aruna Kumari, madam, welcome. Next, Dr. R. Manjula. She is presently a medical director and senior consultant at Sri Srinivasa Nursing Home at Nalgonda, and she's the present president of Nalgonda Obstetrics and Gynec Society. She has a lot of accolades to her, and I welcome madam. Dr. Manjula, would you be kind enough to invite the speaker for today, Dr. Girija Wagh?
Can we see?
Okay. Thank you, Dr. Sneha. And thank you, Niharika, for the kind introduction. So it's my privilege to introduce a good academician and a good intellectual, Dr. Girija Wagh, Professor HOD Department of OB-GYN, Bharati Vidyapeeth Medical College Hospital, Pune, Senior Consultant, Cloud9 Apollo Hospitals, Pune, Faculty Professor, OGASH, International Experts General Coordinator.
It's okay, Aruna. Currently, I'm Vice President FOXY 2024.
Yes,
That's the next position I have, and I'm enjoying that.
Yes.
Welcome. We welcome you, and it's a
Welcome,
privilege.
Dr. Girija.
Thank you so much. Thanks.
Yeah, she's my batchmate and a dear friend. That is, a great introduction for me also.
Thank you so much.
Great
And I
training.
must congratulate my predecessor for giving such an excellent talk. And it was really something which has set up the bar very high. So I hope I am able to deliver what is expected of me. If I'm permitted, I'll just share my slides and I hope you can see them. I'm
Yes.
audible as well as the slides are visible, right?
Yes,
Yes.
ma'am. Yes, ma'am.
So today, since we are talking about the adverse perinatal outcome, we thought that let's speak about the challenges that we experience in stillbirths, because that's something which is very commonly not spoken about. And I want to congratulate Dr. Sneha for creating such wonderful educational platforms all over the country where we get to discuss such complex issues and try to make our clinical practice as simple and as easy as is possible. We all understand that stillbirth has a physical, emotional, psychiatric, as well as a social effect. And on the patients, of course, their relatives and obstetricians definitely. And typically, as we see that the parents will very sadly be saying to the babies, you were born silent, perfect and beautiful, still loved, missed, remembered every day. And never ever does a parent or even a clinician forget an incidence of a stillborn baby which has been experienced in practice. So the delivery of a baby in the perinatal period, which fails to show any signs of life, is typically defined as stillbirth. And the start of the perinatal period, as we all understand, can vary between countries. While in US and India, it continues to be 20 weeks, in UK, 24 weeks. But in India, we are yet wanting to define it because now our MTP age of viability has increased to 24 weeks. So definitely these definitions will require a revision. And that is something that the government as well as the FOXI will have to look into to make our lives easier, because we finally have to write the documents, we have to write the death certificates and things like that. Now, if we typically look at the epidemiology, the rate of stillbirth in high-income countries varies from 1.3 per thousand to 8.8 per thousand, averaging about 3.5. While estimated 22.6 million third trimester stillbirths occurred in 2015 across the country, 98% occurred in the low and the middle income countries. And majority of these in the high income countries resulted due to intrauterine deaths before the onset of labor, which are typically called as antepartum IUFTs, while deaths occurring during delivery or childbirth are called as intrapartum, about 5 to 10%. While if you look at countries like us in the LMICs, the intrapartum stillbirths are much higher. So when we look at the countrywide, and we are talking of Maharashtra, for example, there was a doubling of stillbirth cases in 2019, 5 times the national level, and that was what was shown in Maharashtra. And it was typically recorded from various facilities, and the NMC registered 53,907 total births in 2019 and 58,403 in 2018, with stillbirth cases 1070 against 495 in 2018. And therefore, it comes to 19.84 per thousand births in 2019. And thus, the average stillbirth of country and state was 4 in 2017. Now, government facilitates rupees 5,000 per case for ensuring delivery only at hospital. Despite there being hospital rates, we are seeing that stillbirth rates continue to be causing a challenge. And therefore, when we look at the global statistics, India seems to be leading the entire world in the number of its stillbirth rates. And that is where we have to pay attention. Now, this was something which was written from Delhi, and this was in 2013, where 21,000 stillbirths were recorded. I think there's somebody by the name of DCOTOR who needs to mute themselves. And then you can see that there was an increased rate is found. And when it was further analyzed, it was found to be due to negligence being the main reason in most cases of stillbirth. So naturally, the question comes, why do babies die in utero or even at birth? Now, this is a sort of a review of various cases which were identified and studied. So you can see that case number 1 was treated hypothyroidism. The birth weight of the baby was in the 50th centile. Stillbirth occurred at 40 weeks of gestation. The cause of death was uncertain. So from uncertainty to certainty, you can see there is a wave that you can see in this particular case study. In case 2, there was treated hypertension, Bellamentus cord insertion, birth weight was on the 15th centile, stillbirth at 34 weeks of gestation, again unexplained cause of death. Well-controlled type 1 diabetes, 96 centile birth weight, stillbirth at 36 weeks of gestation, again the death was unexplained. So you can see that nearly the first 5 cases death is unexplained. With cholestasis, elevated ALT and bile acids, birth weight 50th centile, stillbirth occurred at 37 weeks. SLE was another thing, abnormal uterine Doppler at 23 weeks. And this woman had a stillbirth at 25 weeks of gestation. And there was a woman with Sojourn syndrome, anti-RO positive, anti-LA positive, stillbirth at 28 weeks. And this time the baby had hydrops and a heart block. And I understand that most of you, we will be able to find out that yes, probably these deaths must have occurred because of abnormal placentation, placental insufficiency, macrosomia, or any kind of such issues which require to be deeply dived into. While on the other hand, these conditions would occur, still there would not be any stillborns and the babies will be born. So relatively, few losses have a completely understood cause of death, and the remainder have varying degrees of uncertainty in the mechanisms leading to death. Now, if you typically look at the maternal risk factors for stillbirths, and this is a range of characteristics which has been associated, and this was from one of the most systematic, methodologically sound analysis of risk factors, which was performed by the NICHD Stillbirth Collaborative Research Network. And this was also looking at, you can see, the race, ethnicity, then the previous stillbirth history is found to be the most commonest answer. Then nulliparity with previous losses at less than 20 weeks was another very common factor, as you can see. Multiple pregnancies was found to be there. And then diabetes, maternal age more than 40, maternal AB positive, drug addictions, and so on were also taken as risk analytics. And therefore, maybe doing an early pregnancy checklist would at least help you set a stage and to tell the patient that we have to be looking at you. And if we can modify certain modifiable things, we can go ahead and look at it. Likewise, you can see that this was a population-based study which was published in the PLOS Medicine from Bihar. And this was based on the verbal autopsy which was performed. And we must congratulate this study because this was a descriptive data for births that resulted in stillbirth between January 2011 and 2014 in the Indian state of Bihar. And there it was found that the stillborn baby was a boy, then single birth baby, firstborns, maternal age were taken into account, and then first antenatal visit during the pregnancy, health facility delivery, vaginal delivery, and so many such things were corrected and found out, and they tried to find causes. Now, the TULIP classification of perinatal mortality was something which was proposed in 2006, published in BJOG, where introduction and multidisciplinary inter-rater agreement was decided to come under, and identifying why stillborns happen. So the objective of this study was to introduce the pathophysiological TULIP classification system for underlying cause and mechanism of perinatal mortality based on clinical and pathological findings for the purpose of counseling and prevention. And the classification consists of 6 main causes with subclassifications such as congenital anomaly, chromosomal syndrome, single or multiple organ system, placentation or placenta and cord related issues, prematurity, then infection, transplacental, ascending, neonatal, or any other, and others such as fetal hydrops of unknown origin, maternal disease, trauma, and out of ordinary and unknown. And what were also seen as mechanisms of stillbirth were cardiocirculatory insufficiency, multi-organ failure, respiratory insufficiency, cerebral insufficiency, placental insufficiency, and unknown causes. So when we decide to type the stillbirths and approach, the IUD would be typically macerated, extreme prematurity would usually be easier on the facility to explain, while the cause needs to be ascertained because for future planning, we need to know this. IUD near term or post-dated, there can be a possibility of a blame game that we have to face as clinicians. And we keep on wondering whether it was because of GDM, obesity, hypertension, post-datism, intracholestatic hepatitis, unexplained, or FSB, especially intrapartum, most challenging to deal with, especially if there's a cord around the neck or if you have undertaken an instrumental delivery or something goes wrong. So the task is, how do you deal with them? So do you deliver them when you've diagnosed them as antepartum? What investigations do you do? What counseling? And what should be the subsequent pregnancy? Someday everything will make perfect sense. So for now, laugh at the confusion, smile through the tears, and keep reminding yourself that everything happens for a reason. And as clinicians, we need to face it without a judgmental and a rational approach towards the patient. So now, what is the diagnosis, optimal diagnosis of IUFT? Auscultation CTG should not be used to investigate suspected IUFT. It's always better to confirm it with a real-time ultrasound, which is essential for an accurate diagnosis. Second opinion always to be taken if possible. And mothers will keep on telling you that there is a fetal movement many times. And because they are very guilty. They feel that, oh, I did not see the fetal movement. I didn't understand when my baby died. So it's very important that don't rely completely on her. I have had patients who have been sitting outside saying, my baby is moving, doctor. How are you saying that my baby is not moving anymore? And sometimes there can be passive fetal movements also seen after a scan to diagnose IUFT. In that case, always consider a repeat scan. And then, of course, there are secondary features on ultrasound, such as collapse of the fetal skull with overlapping bones, hydrops or maceration resulting in unrecognizable fetal mass, intrafetal gas within the heart, blood vessels, and joints. Severe maceration and gross skin edema can be discussed with the parents. And occult placental abruption, sensitivity can be as low as 15% on ultrasound, as we know, but large abruptions can be diagnosed, and that can be your explanation to the patient why the IUFT occurred. And then after the baby is born, maybe you'll be able to find that there were many loops of cord around the baby's neck or around the entire trunk of the body, especially around the neck, or there was a tube knot which got tightened, and that's why the baby got suffocated and died. Now let's look at this multipara, the fourth vaginal delivery, who was admitted at 5 centimeters, 1.5 hours post-admission. You can see that there is a complete sudden drop. And this typically happened because of a placental abruption. In the upper panel, you can see that the fetal skull electrolyte first detected the heart rate of the dying fetus. After fetal death, the maternal electrocarb complex is detected and recorded. And the second panel displays an absence of the uterine contractions. So you can see that this was the patient that we had hospitalized, and this is something which I've taken as a screenshot from a textbook, and it's showing that even after the fetal demise, sometimes the CTG would show a cardiac activity, putting you into a quandary as to what really is happening. Now, breaking this bad news is a definite challenge. And the late IUFT poses difficulties as it is often sudden and unexpected. And therefore, it's very important to determine the emotions and needs of the mother and her companions, identify and understand the woman's thoughts and wishes, but without trying to shape them. Women with an IUFT and their partners value acceptance and recognition of their emotions. I always allow the patient to speak. You don't sort of put emotions onto their brains. We don't know how they are going to take, and that should be very, very unique and individualized for them. And pregnancy loss can quickly result in vulnerability, and therefore imposing care can worsen the psychological impact. I have had a patient whom I saw that it was an IUFT. I got a second opinion also done, but she continued to say, no, doctor, my baby's heart is still there. I gave her a time to understand, take a call, and then decide it was a huge macrosomic baby. And she had missed her antenatal visit, and also probably the DFMC didn't come on time for some reasons in the family. And finally, we had to take out that baby with a cesarean section because it was a big baby. It wasn't going to be delivered vaginally. It's a very big decision, and you have to allow them time to think and not pressurize or push the patients unnecessarily. And therefore, the question comes is, will you give a death certificate in following gestational age? And this is a question which I can ask the audience. If you are there, please put it in the chat box. Let me know what you would say. A death certificate more than 24 weeks of gestation, 20 weeks or more than 28 weeks. I think I would always give it to more than 20 weeks as well, because that's currently the guideline, and none of our local authorities have told us to call it yet. a non-abortus, or it's a viable baby, or a definition in our country is still 20 weeks, and therefore 20 completed weeks onwards will be receiving a death certificate according to me. But I would be interested in finding out what your states are saying. Now, maternal well-being also has to be taken into account. There can be a life-threatening maternal disease which is causing this particular death, and therefore proper evaluation of the mother with detailed history, clinical examination. It could be preeclampsia, chorioamnionitis, placental abruption, and there's also a moderate risk of DIC, 10% within 4 weeks after the date of late IUFT, rising to 30% thereafter. Clotting studies, blood platelet count, and fibrinogen measurement can do the trick. And you have to remember, I have had instances where some of my colleagues in their private practices have decided to deliver the patient of IUFT, and they have landed in a torrential PPH, and they had to refer it to us. And therefore, my message always is, if there's an IUFT, there's something gone wrong, and this patient would require a care in a proper hospice where you can immediately initiate any additional care if it's necessary, especially when babies die after 28 weeks of gestation. We must be looking for certain maternal underlying conditions. Investigations in IUFD have to be clinical assessment and laboratory tests, as I mentioned, to assess the maternal well-being, including coagulopathy, to determine the cause of death, the chance of recurrence, and further pregnancy complications. Now, there has been no specific cause found in 50% of the stillbirths. If found, crucially influence care in the future pregnancy. Abnormal test results is not necessarily related to the IUFT. Correlationship between the blood test and the postmortem examination is essential. Further tests might be indicated following the results of the postmortem and good practice systems. So therefore, it's always better to do a fetal autopsy. And the good practice says systems that use customized weight charts and capture multiple contributing factors to categorize can help us in identifying these problems better. Another challenge is delivering an IUFT. Again, one more question for the audience here. In the third trimester, would you wait for an expectant management, or would you want to induce this pregnancy? So you can just write induction or expectant management in the chat box. At the end of my talk, I'll look into it. My preference will always be induction. And if she at all has some torrential problem, like she is very anemic or she's having any problems which require to be stabilized, I would undertake those. Maybe she's having, very low hemoglobin. We may do corrections or hypertension and then optimize her health within 24 hours and do an induction and deliver her. Now, so when do you do an induction? As soon as possible. No expectant management. 14 days natural onset has been observed in studies. Labor induction immediately after fetal heart rate was not recorded. Stabilize if necessary for comorbidities, as I mentioned. The contraindications would be scarred uterus, abnormal lie presentation, poor bishops, and comorbidities such as abruption or febrile illness. You would not prolong her induction, and you may have to consider a swift delivery. Now, how do you induce these patients? You can use a mechanical dilator. We do not have those cervical balloon catheters easily available, so we always double up to use a Foley's catheter. Hydroscopic dilators such as Dilapan have been found to be useful. I've used some of them, and prostaglandins in the form of either a pessary or a gel or a misoprostol can be used, and augmentation always with oxytocin, and do it judiciously. There should be a low threshold for C-sections, avoid unnecessary prolongation. Instrumentation can be a challenge in macerated babies, and analgesics should be very liberal and empathetic because patients are really going through a very tormenting experience. Now, if you have an intrauterine fetal death near term for induction of labor, what would you prefer? Misoprostol, prostaglandin gel, oxytocin, or mechanical dilator? Now, many a times, the best results have been found with a combination of a mechanical dilator and a prostaglandin gel if the bishops is poor. Some people have used misoprostol, and it's always better to use the FIGO misoprostol guideline, which is wonderfully written. What should be the dose and the frequency? And that if you use, you'll usually not go wrong. Should you use mifepristone preceding to induction of labor in IUFT near term? Yes or no? Now, this is a question which you can answer, but many would answer yes, because mifepristone is known to sensitize the uterus to the action of oxytocin and would shorten the duration of induction. So the combination, so what's the evidence for prostaglandins? Combination of mifepristone and misoprostol, average delivery time of 8 hours, mifepristone 200 milligrams. Standard dose reduced the time interval by about 7 hours. An RCT was conducted with using IV oxytocin alone versus per vaginal misoprostol, and misoprostol was found to be more effective. Misoprostol used for late IUFD recommended dose at gestational age 100 micrograms 6 hourly before 26 weeks and 25 to 50 micrograms 4 hourly at 27 weeks or more. And misoprostol can be safely used for induction of labor in women with a single previous C-section, but be very careful with the dosaging and close monitoring of the patient. Now, if the patient is IUFD at term, cephalic presentation, and no comorbidity, what would you be choosing? A vaginal delivery or a C-section? I think I would choose a vaginal delivery. I hope you also have the same answer. Put it in a chat box and we'll understand this. Now, when do you do C-sections? There are limited inductions in stillbirth. Relative high morbidity and future fertility is associated. So women with 2 previous lower segment scars should be advised regarding the risk of induction with prostaglandins, higher than for women with a single previous C-section. And in patients with more than 2 lower segment scars or atypical scars, the risk of labor induction is unknown. And absolute indications would be cephalopelvic disproportion, fetopelvic disproportion. I gave you an example, obstruction, because that could be an obstruction and can cause more problems. Malpresentation, placenta previa, or morbidly adherent placenta, of course, and conditions which are non-conducive for induction of labor. The common indications of C-section, therefore, would be gestational hypertension or preeclampsia, placental abruption with massive bleeding. Not all gestational hypertension preeclampsia, mind you, the ones which are severe conditions where prolonged induction of labor may not be amenable. Twin pregnancies, when one fetus is living and one is dead, breech transverse lie, previous C-section, breech presentation, placenta previa, myoma, macrosomia, and failure of induction of labor or prolonged labor. Now, in a single lower segment scar, induction of labor should be conducted with prostaglandins with minimal risks. And Bishop score more than 6, oxytocin can be used, close surveillance, and avoid an undue delay. Now, IUFD in an Rh negative mother also is a special consideration. Always give anti-D prophylaxis. The potentially sensitizing bleed might have occurred day before the IUFD. Effective window for optimal timing of anti-D gamma globulin administration is 72 hours. Step-up dose if there is a large fetal-maternal hemorrhage. Clearheart test is usually proposed by many studies, but it's not very easily accessible. Even in our tertiary care center, we don't find it easily amenable. Baby's blood group, if no blood sample can be obtained from the baby or cord, then free fetal DNA can be done from maternal blood taken shortly after birth or from the cord. And major fetal-maternal hemorrhage is a silent cause of IUFD, and a clear test is recommended for all women to diagnose the cause of death. Now, associated medications and care, DVT prophylaxis adjusted to the individual clinical and biochemical profile. Documentation is very important, information, counseling, consents, and detailed notes, because next time she may not come back to you. And even if she comes back to you, you may have forgotten what had happened. Lactation inhibition by cabergoline, bromocriptine, or pyridoxine can be considered. Dopamine agonists are contraindicated in women with hypertension or preeclampsia, and they can increase blood pressure and have been associated with intracerebral hemorrhage. So a word of caution there. Now, whenever you have a stillbirth, it's always a good practice to put in this algorithm in front of you. 1, are there any clinical key clues? If there are no clinical clues, then genetic testing, APLA, fetal maternal hemorrhage testing and other testing is required. Fetal growth restriction or hypertensive disorder, again, the same kind of thing can be considered. And suspected fetal anomaly, genetic testing and other testing is required. Intrapartum stillbirth, again, the same things may be necessary to corroborate an evidence. And preterm labor, chorioamnionitis, PROMs, other clinical scenarios, further testing based on clinical suspicion, remaining tests of limited utility. It's always a good practice to do a placental pathology analysis and a fetal autopsy. And there are various insights that you can get through a fetal autopsy. You can see various pictures that are put across here, and these can throw a light, give us an assurance, and give us a good reason to explain to our patients, and also for a better planning in their future pregnancy. So inspect the fetus in the placenta for weight, head, circumference, and length of the fetus, the weight of the placenta. Take photographs frontal and profile photographs of the whole body, face, extremities, palms, and any abnormalities, obtain consent from the parents for cytogenetic specimens, obtain cytogenetic specimens with sterile techniques and instrumentation. Amniotic fluid obtained by amniocentesis at time of prenatal diagnosis can be considered. Placental block of about 1 to 1 centimeters and taken from typically below the cord incision site on an unfixed placenta. Umbilical cord section for 1.5 centimeters. Internal fetal tissue specimens such as the costochondral junction or patella skin is not recommended. Place specimens in a sterile tissue culture medium or lactated ringers in solution and keep at room temperature when transported to cytology laboratory, and do not place specimens in formalin. Now, obtain parental consent for a fetal autopsy, and placental pathology may include fetal whole body X-ray. Sometimes even in some centers, they may recommend taking an MRI for these babies. If no consent is given for autopsy, external evaluation by a trained perinatal pathologist can be considered. Other options include photographs, X-ray imaging, ultrasonography, magnetic resonance imaging, and sampling of tissues such as blood or skin. So management of subsequent pregnancy after stillbirth is another challenge. Always encourage them to come for a pre-pregnancy or initial prenatal visit, where we can consider doing a detailed medical and obstetric history, evaluation and workup of prior stillbirth, determination of recurrence risk, smoking cessation, lifestyle immunization, weight loss in obese women pre-pregnancy only, genetic counseling if family genetic conditions exist, diabetes, hypothyroid screen, hypertension optimization, and anemia correction. Acquired thrombophilia testing should be done, and support and reassurance. And sometimes in very, very recurrent stillborns, we can consider giving them an immunotherapy before, like ecusilam and some such kind of coagulation inhibition therapies can be given in these patients of thrombophilia before conception. In the first trimester, do the dating scan, first trimester screen, and combined testing at exactly 12 to 13 weeks. Second trimester, fetal sonographic anatomical survey at 18 to 20 weeks, but I would also recommend an early anomaly scan at 16 weeks itself. Quadruple marker test or a single marker alpha fetoprotein if first trimester screening was already performed. And then third trimester sonography screening for fetal growth restriction at 28 weeks onwards. Antepartum fetal surveillance starting at 32 weeks of gestation or 1 to 2 weeks earlier than previous stillbirth. And then you can also consider delivery usually should be in a good center, planned delivery at 39 to 7 weeks of gestation or as dictated by other maternal or fetal comorbid conditions. In cases of severe patient anxiety, where there is a preference to proceed with early term delivery, 37 to 37 weeks or 38, 6, 7 weeks, to prevent recurrent stillbirth, increased risk of neonatal complications with early term delivery compared with a potential benefit, and antenatal steroids can be considered depending on what the guidelines are. So in the last slide, I would like you to answer these questions. Question number 1, IUFD in the third trimester, induction or expectant management. We discussed this already. IUFD at term, cephalic presentation, no comorbidity, vaginal or C-section. Near term for induction of labor, what do you prefer? And mifepristone preceding misoprostol. And I'll look at the chat box after I finish talking. So we must remember that we must accept the finite disappointment, but never lose infinite hope, as Martin Luther King Jr. has mentioned. And I take this opportunity to urge all of you to not forget my dear friend, Dr. Snab Buar. Please vote for her. And I want to see her as the Vice President of FOGSI, taking ahead the organization in the way that she has been doing already. And we should always encourage people who have been diligently, academically, and constantly taking the organization ahead. And I also take this opportunity to invite you to the Vice President's International Conference, which is scheduled in Pune on the 26th and 22nd of October. Please mark your diaries just now. And please feel free to connect to me. It's going to be a wonderful, lovely 48 hours, which will be spread in Pune. And I promise you an extremely academic feast, which you'll learn. And I feel that this is, again, our contribution giving back to the society, because preterm births in our country are extremely high, and we must do something about it. Thank you so much for giving me this patient hearing and the screen, and I hope I have been able to deliver to your expectation. Thank you.
Thank you, Dr. Girija ma'am, for such an exceptionally well talk. And I think you've kept all of us on our toes with all the questions that you've asked. So I invite comments from the chairpersons.
Good evening, everybody. First, let me thank Madam Snab Buar, Madam, for giving me this opportunity, and Niharika and Sailaja also. Madam Girija, Madam, it's really an excellent talk on the stillbirth. You covered each and every aspect of stillbirth in a clear and crisp manner, starting from the counseling, causes, how to manage delivery, postpartum examination, future pregnancy. You have left nothing for discussion. It's really excellent talk, Madam. It's a small question from my side. Am I audible?
Yes, Dr.
Yes.
Madam, if a patient with IUFD with previous 2 cesareans at 28 to 30 weeks, what is your stand, Madam? Will you induce her or advise?
So we would actually consider induction. It would be a better option for her. But of course, as
Previous 2 cesareans, myomectomy scars.
Yeah, but it's always better to do try and induce her if possible.
Which method, Madam?
Taking a longer time, I would use a mechanical along with a PG gel.
Oh.
Or the misoprostol low dose regimen, which starts with 25 to 50 micrograms. And if that's not showing any response or a progress, then we may have to consider taking her up for a, we can't call it a C-section. It will be a hysterectomy. Yeah. But then, we are putting her again at a risk of a scarred uterus and a morbidly adherent placenta in the future, which is usually associated with preterm births. So always it would be better to give her a possibility. And currently, if you look at the ACOG guidelines for previous 2 sections, they are saying that we can consider doing induction of labor by individualizing the condition that is there. So whenever, and I always believe, and I think Sneha will agree to me that whenever we were working, even as residents and later on, when you are there by the patient, usually nothing goes wrong.
Yes. And that is how we have been brought up, vigilant monitoring.
Vigilant monitoring. If you are there, then you know what's happening. If you leave it to somebody, then, and these are special patients, so they should not be left to somebody.
Yes. So wonderful. I'm sure this was an academic treat for everybody of us. And I'm very happy that, very proud of you, my dear friend. You delivered the best, of course.
When you ask me to talk, I have to deliver, no? Because otherwise you will ask me questions.
No, my dear. Only one query from my side, that what question you asked just now, previous 2 cesarean section with IUFT, will not the mode of delivery or the induction differ if at all she has previous to live issues? So if she has previous to live issues, because para 2 with previous 2 cesarean section, now this time IUFT. So if she has previous to live issues, we not go ahead with hysterectomy TL. I would just ask you.
That's what I said. It would be an individualistic approach depending on what has been a previous perinatal outcome. What are her wishes? Sometimes, they don't want that 3rd baby and they have just got into it and they took it ahead. But even if it's a stillborn, our responsibility of investigating why a stillborn occurred from the maternal point of view doesn't stop. So that always has to be kept in mind, because IUD, as I can see my mentor and teacher here, Dr. P.K. IUD is a penultimate thing where we just told you that something has definitely gone wrong and we must investigate it. If not for the baby, at least for the mother, definitely.
Yes. In this stillbirth, not only the management, the empathetic counseling and the straightforward manner explaining them in a private room, let them allow to ask their doubts is very important. Madam already covered everything. The counseling plays a very important role in these cases.
Because, it's a negative outcome. And if you make any kind of faces or if you say some comments, to be very proper when you're speaking to these patients. They will pick up that negative thing only. And they will get extremely disturbed. So our aim and objective should be that we should not get them disturbed. The moment they are disturbed, they will immediately leave your table, go to somebody else for a second opinion. So be patient. I always feel that it's always better to make them talk first. Let them tell us, why do you think this must have happened? So many times they have come to some conclusion. They have understood that things have not been going right. And then you give your thing. They will ask you, doctor, what do you think? So this little bit, it takes a lot of time, but we must show that much empathy, especially, and fortunately in our practices, like I can see the audience who's here, we have a very, very sort of a controlled practice where we are directly in contact with our patients. Unless and until it's a big institutional practice. So for me, even in an institutional practice, usually when adverse outcomes come in, we very serious senior doctors only do the counseling. We have made it as a practice. So we are usually one-on-one with our patients. And then in that case, we can give them that much time. We don't have such an, it's not such a common thing that's happening in our lives. So we must spend time with them so that they don't take a very bad feeling and go back.
Thank you so much, madam. Thank you so much, Dr.
The
Girija.
blame game, doctors unknowingly try to put the blame on the mother. You did not see the DFMC well. Like I told you my example. You did not come on time. Actually, she had not come on time, but I never blamed her. I said, you never know, it can happen this way. Let's see, let's check.
Positive counseling plays a role. It's very important. Very important. I agree. And I think the practice of doing a fetal autopsy in these cases is also very important. And I think we should all inculcate it. And genetic
And you have no access to a geneticist or a perinatologist, which we have in our place.
Yes.
You can just take good pictures.
Yes, ma'am.
And then now be placental histopaths and all things are happening actually. We can
we are doing on a regular basis, even in our institute, ma'am. Yeah. Thank you so much, ma'am. I thank all the chairpersons.
And I will also make a point which our teachers used to tell us when we were residents again, is that whenever there is an adverse outcome, be it a missed abortion, be it an abortion or preterm birth or an IUD, write a good history. Your conclusion, something you write. So we used to call it as a verbal autopsy.
Okay.
You understand? Write it nicely in that history. Let it go on the discharge card. Our teachers used to be insistent. If you have taken a incision, which is a T-shaped incision, we were made to write on our discharge card that the next time you will always undergo an elective C-section.
Yes.
Like that.
Thank you so much. The best, Madam Sneha.
Thank you so much, Girija, for that, really thought-provoking presentation also, and lots to learn, I think, for all obstetrician as well. I think with this, we thank Dr. Girija and we go ahead with the panel discussion. So, Niharika.
Thank you, ma'am. I hand over to Dr. Shailja.
Yeah, ma'am. Our next session is the panel discussion on preterm labor being moderated by none other than Dr. Snab Buar and with our expert being Dr. Bharti Rajshekar. Dr. Bharti Rajshekar is the IMA State Past Vice President, IMA Executive Member, Past President Hassan Society, Past Secretary and Committee Member.
Yeah, current President of Kasuga, I think that's the highest post she has. And she's an aspirant for
Present President of Karnataka State Obstetrics and Gynecology Association.
So we welcome you, Dr. Bharti.
Welcome, Dr. Bharti, madam. Can I have the CVs of the panelists, please? Dr. Manjusri, who is a consultant obstetrician and gynecologist at Anu My Baby Hospital, Vijayawada, with K2MS certification in perinatal training and training in ultrasound at Selvi School of Sonology, Chennai, and a master's course in cosmetic gynecology at Delhi. Next, please. Dr. Sushma Meda, fetal medicine consultant at Sri Krishna Nursing Home and certified in NT and anomaly scans by Fetal Medicine Foundation UK and certified by IOTA and Fetal Medicine Telangana Chapter Executive Member. Next, Dr. Satya Shilpa, Assistant Professor OBGYN SVSMC Mehboob Nagar with special interest in high-risk pregnancy and vaginal surgeries. Next, Dr. Shilpa, Professor SVS Medical College Mehboob Nagar with special interest in teaching students and being a part of research. Next, Dr. Devi Sri, who is currently working as Secretary for Rajahmundry Society and working as a consultant in Jaya Hospitals, Rajahmundry. I welcome all the panelists. Dr. Sharda, who is presently consultant at Rohini IVF Center, Amlapuram. Yeah, I hand over to Dr. Snab Buar, madam, for the panel discussion.
Yes, so a very good evening to all of you. First of all, Let me thank all the president secretaries of all the 4 societies. I have already welcomed you. Personally, I have named you, and I'm very happy to have all the learned panelists. And without much ado, we go ahead with the panel discussion. So I hope you can see my screen. I'll just make it full screen. And yeah, so as we have been, even in between the talks, we are having a very good, healthy discussion, because I'm sure all of you will agree to me that discussion is always to know what is right. And we are here to know what is right, not who is right. So I would just start by, saying these basic things about preterm labor. All of you know what preterm labor is. Preterm, that is before 37 weeks, and labor in this presence of actually the uterine contractions, which are progressive in nature, having the effect on the cervical dilatation and effacement. So progressive effect on the cervix. And how does it happen? Why does it happen preterm? What are the effects at various levels? That all of you know that, just to revise, the cervix and myometrium, there is suppression of the inflammation and thereby reducing the myometrial contractility. At fetal membranes, you have, it blocks the pro-inflammatory cytokines, induce apoptosis. At placental level, it regulates the timing of labor via controlling the stress hormone CRH. And at amniotic fluid level, it is about the production of the prostaglandins. So we would go ahead with the preterm labor as such, and we would go ahead with the the discussion. We have Dr. Manjushri. This is a case for you, Dr. Manjushri. We have this 28-year-old primary gravida with 31.5 weeks of gestation. She's presented to you in casualty at around 3 a.m. with complaints of abdominal pain. When you examine, you find the pulse rate is normal, but the BP is slightly higher, 120/90. And uterus is 32 weeks irritable, fetal heart is good. Cervix is posterior, external os admits tip of finger, cervix is short, but there is no show or leaking. So what is your diagnosis? Rather, I would say, how do you analyze and come to the diagnosis? We start from that.
Good evening, ma'am, everyone, and good evening. Thanks for giving this opportunity, ma'am. So here, the woman is a primary gravida at 31 weeks, presenting with the abdominal pain. She's uterus is measured around 32 weeks. It is irritable, suggesting presence of contractions. And on per-vaginal examination, the cervix is slightly dilated, indicating that early cervical changes and effacement. So, the most diagnosis for this patient presenting with abdominal pain, uterine irritability, and cervical dilatation at 31 weeks, I say that she is into threatened early preterm labor.
Right. So I would just say, just make you stop here. Is it not a false preterm labor? Are these not false labor pains? In other words, I would ask you, what are the typical characteristics of these labor pains?
True labor pains, we see frequency of the contractions, like 3 to 4 contractions in 10 minutes.
Yeah, that will be good contractions.
Yes.
But at least whether she's really having the regular contractions, that is what you have to see, right?
Yes,
okay. So whether she is in false labor or true labor, let us clarify this first. First and foremost, you said it right. Yes, there are regular uterine contractions, and the classical pain of uterine contraction, how does it happen? What is whether it is only in the front of the abdomen or it comes from back and goes down?
From back, yeah. We need to ask from the patient whether she has a back pain which is radiating to the abdomen.
Correct. And whether she has
the frequency of the contractions
and the intensity. Correct. And then we can come to know whether we can conserve this, or rather whether we should conserve this. So how do you decide that whether we should conserve this patient going into the established preterm labor? How do you differentiate? Now that we have come to conclusion that it is not a false preterm labor, but it is a threatened preterm labor, true labor but threatened. So how do you differentiate between the true threatened preterm labor and the established preterm labor?
So we need to monitor for the contractions, ma'am. And if any changes in the cervix are there.
Yes.
So depending on the cervical changes, we can say whether she is going into from the threatened to established preterm labor.
Correct. So whether for that you need to examine this lady, right? So
Yes.
whether you want to go for internal examination, whether you will go ahead with the speculum examination first, sterile speculum examination first, and look for what, and whether you would like to go for the vaginal examination and look for what? Progressive changes, you said, no? Dr. Sushma.
Yes, ma'am. Good evening, ma'am.
Good evening.
Thank you very much for giving me this opportunity.
Good.
So,
pleasure.
Would you do a sterile vaginal examination in this situation? Yes, ma'am. In this situation, because she's not complaining of regular contractions, I would have two options, ma'am. Either doing a sterile vaginal examination or doing a transvaginal scan if it is available.
Okay.
For the cervical length. If she is actively contracting, then maybe I would have preferred to do a sterile vaginal.
I just ask you one question, whether you would like to go ahead with a speculum examination, sterile speculum examination, before going for a sterile vaginal examination. Speculum examination.
Speculum examination would be required to assess if there is any leak.
Yes, so to see for
and
leak.
also, yes, ma'am. And also, if I wish to take a swab for culture, I would do a speculum examination.
Right. So now that you are doing her speculum examination, you don't find that there is any leaking, frank rupture of membrane, and then you go ahead with the sterile vaginal examination. Then how do you decide at what level you find that it is a established preterm labor? How do you decide that?
Depending on the cervical findings of dilatation and effacement.
Right.
If the cervical dilatation is more than 3 to 4, it is a advanced preterm, late
4
preterm.
centimeter. Right.
Yeah, established preterm labor.
Okay.
If it is between 1 to 4, then it is an early preterm labor.
Yes. You did talk about the ultrasound. So you said transvaginal, that is for the internal changes. But what is the role of ultrasound for these patients?
Role of ultrasound in general, firstly, to assess the cervix is we have to do in an empty bladder transvaginal ultrasound.
Yeah, but before that, will you not go for the routine ultrasound, obstetric ultrasound?
Yes, ma'am. Routine obstetric ultrasound examination is to see the weight of the fetus, liker, and how many number of fetuses are there. And I'll also see the previous ultrasound records if the dating is confirmed.
Yeah.
If a dates.
Yes. And what is the status of the fetus right now? What is the biophysical? Right?
Yes.
Yeah. So because if the biophysical is poor, there is no point in conserving this pregnancy. Correct?
Yes, ma'am. And also with NST, we have to correlate it with NST
Right.
if there is any deceleration or not.
Right. So if you have this patient as threatened preterm labor without rupture of membranes, then what will be your approach? Dr. Satyashilpa. Dr. Satyashilpa. Do we have Dr. Satyashilpa?
Yes, ma'am. Hello.
Yes, please, Dr. Shilpa. We have come to the conclusion that this patient is in true preterm labor and that he is in threatened preterm labor. Correct?
Yes,
She doesn't
ma'am.
have
Yes,
rupture
ma'am.
of membrane. So what is your routine approach of management for this patient?
Ma'am, now her membranes are not ruptured. So I would like to check her cervical length, ma'am.
Yeah.
I mean, like ma'am have already suggested, ma'am will do like TVS to check the cervical length. And next, my first step will be relieve her pain, ma'am, first, because she came to a casualty with pain.
Yeah, but that's it because of the contractions.
Yes, ma'am. So I'd like to give her Tocolytics, ma'am.
Okay,
Most,
now comes the question.
ma'am.
What is the rationale for giving the tocolytics?
Ma'am, tocolytic I'd like to give her because I want to cover her with the corticosteroids, ma'am. I would like to take time to cover this with corticosteroids at least for
How much
48
time do
hours.
you want and what steroids you want to give? What is the schedule?
Ma'am, recommended corticosteroids are like betamethasone and dexamethasone, ma'am, or dexamethasone. Betamethasone, we can give 12 mg 24 hours apart, ma'am. Sorry, and dexamethasone 6 mg 12 hours apart. 4 doses we can give, ma'am.
Yeah, not to get confused, even IFP and FOXY, both the organizations, they have accepted that whether it is betamethasone or dexamethasone, because, not to go into the controversy, whether it is betamethasone or dexamethasone, 24 milligram over 24 hours. Okay. That
Yes, ma'am.
gives
Yes,
you
ma'am.
a good fetal maturity, because in the Western world, they are using betamethasone, but the salt which they are using is not available in India. Okay. And what
Yes,
we are using routinely, even the government of India is recommending dexamethasone.
Dexamethasone. Yes,
Yeah. So
ma'am.
24 milligram over 24 hours, that should be good enough, right? So, okay.
Yes, ma'am.
So you want time for the steroids, and also
Yes, ma'am.
what else? What else? What is the rationale for this? One is you want to buy some time for steroids to act, and second,
Yes, ma'am.
because it
And,
is in 32 weeks, you will also need a neuroprotection.
Yes, ma'am. Magnesium sulfate. I'd like to give her magnesium sulfate, ma'am, for neuroprotection.
Yeah.
Because based on some multi trials, it is it has been proven that magnesium
We
sulfate.
can talk practically. No need for any references. Whatever you are practicing, we want to share. Right.
Yes, ma'am. We'll start with magnesium sulfate, ma'am, to give her neuroprotection.
Yeah.
First, loading
Because
dose.
these are the proven facts. So we
Yes,
need
ma'am.
not quote any references here. These are the proven facts. Okay.
Okay,
Steroids
yes, ma'am.
definitely improve the lung maturity, and
Yes, ma'am.
magnesium sulfate has proven beyond doubt that it is a neuroprotector. Correct?
Yes, ma'am. Yes,
Okay.
ma'am.
What is the role of bed rest? Bed rest, reducing stress. You can see here I have quoted all the management modalities. So how do you justify? What is the role of bed rest?
Bed rest is not really required, ma'am, for this patient.
Okay, so what rest is required?
Sorry,
It is
ma'am,
not
what
bed
rest?
but
Ma'am.
it is adequate rest, we can say.
Yes, yes, ma'am.
But
Yes, ma'am.
definitely not to have intercourse, not to have repeated internal examination. So
Yes,
maybe
ma'am.
not to lift heavy weights or push something. So not to go for any strenuous exercise. So what we label this as the pelvic rest. Okay.
Yes, ma'am.
Pelvic
Yes,
rest. Okay.
okay.
So what is
Yes,
the
ma'am.
role of reducing stress? Does it play any role?
Yes, ma'am. Obviously, reducing stress will help in this threatened preterm labor patients, ma'am. It will reduce the
Role
chance
of
of her getting
politics you have said already. What is the role of progesterone now?
Ma'am, progesterone is also recommended, ma'am, because it is proven that progesterone will help in maintaining the cervical length, and it prevents the start of this labor, ma'am.
But your patient is already in threatened preterm labor.
Yes, ma'am.
Yeah. Anybody else?
Can I add, madam?
Yes, Dr. Shilpa, you have said everything very nicely. Only thing is, what role of progesterone? What is the role of progesterone? Whenever you are using some tocolytics, to combat the active uterine contractions, that means in the acute phase of your preterm labor, you are giving this progesterone to keep the uterus quiescent, because we have said that the progesterone acts at 4 levels. Okay, the first diagram itself I have shown you. Yes, I can see Dr. V. Sharada raising hands. Yes, please go ahead. Please unmute yourself, Dr. V.
It's me, Dr. Shilpa.
Dr. V. Sharada, please unmute yourself. Please unmute yourself. No,
Sharada, we can't hear you. Please unmute yourself.
Okay.
Correct.
Am I audible, ma'am?
Yes, yes, right.
Good evening, ma'am. Thank you for giving me this opportunity.
I'm Dr. Sharda from Amlapuram. It's a town in Andhra Pradesh. It's like
Nice to meet you. Yes.
like a Kerala. It's a second Kerala in Andhra Pradesh.
Okay.
Just for information, ma'am. I
Good.
wanted to tell about the role of progesterone in preventing preterm labor, ma'am. Actually, the mechanism is it decreases the conduction of the myometrial contractions, progesterone, and it increases the threshold for stimulation of a contraction. It decreases the number of oxytocin receptors also, and it prevents the formation of those gap junctions and causes relaxation of the uterine muscle. So in this way, it can protect labor pains from happening. And if it is usually, I prefer to give it in an injectable form, 250 micrograms of injectable progesterone weekly once, beginning from 16 weeks to it will continue from we can start around 16 to 20 weeks if there is a threatened preterm.
Correct. But what
And
you
we
are
can
saying
continue,
is as a prophylaxis.
till 36 weeks also,
Yeah.
weekly once.
Right. What you are saying is as a prophylaxis. What we are talking is your patient has already had threatened preterm labor. After your acute tocolysis, you want to maintain her and take this pregnancy ahead. So here comes the role of vaginal micronization.
Vaginal pessary, vaginal progesterone regularly.
Correct.
200 mg will give
200 micrograms of vaginal pessary.
Oh, at least 400 milligram per day, right? 200 milligram twice a day or 400
twice day.
Yes.
Twice
So
daily
now,
200.
Yeah.
Yes.
Yeah. So Dr. Shilpa, do we have Dr. Shilpa?
Yes, ma'am.
Yeah. So
Good day.
welcome, Dr. Shilpa. So
Thank
this
you, ma'am.
patient initially when you examined, there was no leaking. Okay. But now you have, covered her, you have stopped her contractions, and now you are maintaining her on vaginal progesterone. But suddenly you find that she gives you history of leaking. Okay, when you examine, do a sterile speculum examination, you find there is a pool of amniotic fluid. Now, how do you, suppose you find there is a pool of amniotic fluid, and you smell it, maybe you confirm it by your experience, that is well and good. But sometimes you feel that there is a doubt whether it is a pool of amniotic fluid or it is just a vaginal discharge mix, or maybe just a urine sometimes contaminated. How do you confirm that?
Yeah, madam. So actually, NICE guideline doesn't recommend nitrogen test anymore. And then we have the Fern test, but then blood and mucus can contaminate it.
But before that, clinically, can you confirm? Suppose you have some fluid there, you can wipe it out.
Clinically, first thing is we have to do the per abdomen examination. First, proper history, whether the quantity of the leak is important. Is it whether it is continuous or only it is intermittent, or she appreciated only recently, just past hour or half hour. That gives a better idea.
Correct.
Then our examination, per abdomen examination, whether the fundal height is corresponding or not, will help. Then the sterile per speculum examination.
What do
if
you
there is
do?
a pool,
What do you
then
ask
there
the
is no
patient
problem.
to?
We ask the patient to cough once.
Correct.
Or we ask her to sleep left lateral and change the position, and then we examine again.
Correct.
So if the pool is collected, then it confirms.
Yeah, I can see Dr. Sushma raising her hand. Do you want to add anything?
Yes, ma'am. In the previous question, you are asking about the role of stress in preterm labor.
Yes.
So stress in the mother activates maternal hypothalamo-pituitary axis. First, from the hypothalamus, corticotropin-releasing hormone is released, which in turn activates ACTH from the pituitary, and then cortisol is released. This one in turn acts on the placenta, and also fetal hypothalamo-pituitary axis is activated, and thus it causes preterm labor.
Okay. So what about, that is what we have initially said, that CRH definitely has, the stress hormone definitely has a role in the onset of labor, right? And that is how the stress plays an important role. So what about this pool of amniotic fluid? Suppose if you still have doubt, then how do you confirm? Even when she's coughing, you find that there is no leaking, then how do you confirm?
We can do an ultrasound examination, madam.
Right.
We can do an ultrasound examination and see for the Liker pockets. Definitely, if she has an recent scan, which had a proper liquor, and now if she is leaking, and we can see on ultrasound itself that her liquor pockets are decreased.
Yes.
That is
Do we
one
have
way of
Dr.
the.
Yeah.
Hello.
Do we have Dr. Bharati here? No. Okay. So now we have said what is the rationale of the tocolysis. Dr. Shilpa has initially asked this, but still you want to have fetal maturity, that you want to wait for 48 to 72 hours for the steroids to act. Sometimes you do not have the facilities for NICU, and you may need the in utero transfer, and of course you need 24 hours for the magnesium sulfate. That is how is the rationale for. So I would ask you, Dr. Devishri,
Madam,
what is the rationale for the long-term tocolysis? Dr. Devishri? Do we have Dr. Devishri here? No?
Yes, ma'am.
Okay, Dr. Bharti is here.
Dr.
Yes.
Devishri, she's logged in, madam.
Yeah, but then I mean, she's
Not
not responding. Can anybody see her? Can somebody call her?
Yes, madam, I'll call her.
Yeah, by the time Dr. Bharti, we can have one comment from you. We have invited you already.
First of all,
Madam, I would want to add on progesterone, role of progesterone, madam.
Okay, please go ahead.
So there are only two
Just the
progesterone.
question what I ask you is that we have given her, done her acute tocolysis. What is the role of long-term tocolysis?
There is no role for long-term tocolysis.
Correct. That is what the answer is. We have talked enough about the progesterone. We have said that vaginal natural micronized progesterone definitely has a place once you combat the situation of threatened preterm labor, right? So, Dr. Bharti.
Yes, thank you, Dr.
Comment
Sneha.
from you.
And excellent deliberations going on. And I thank the AMOGS committee as well as all the societies of Andhra for giving me the chance here. And I'm sorry I was late because I had an emergency. And coming to the topic, as you said, yes, there is no place for long-term tocolysis. But of course, after the has become quiescent, to prolong the pregnancy, either oral dydrogesterone or even micronized vaginal progesterone in 200 milligrams is a very good option to push the pregnancy at least up to 35-36 weeks, so that the fetal outcome is definitely going to be good. And along with that, I think if she has been presented with abdominal pain and some sort of a discharge, you can always use probiotics. This is what I use in my practice. After the tocolysis is given and the uterus has become quiescent, when she goes home, I send her with a course of probiotics, because this definitely reduces the inflammatory process and the vaginal microbiota improve, and that also will reduce her chances of preterm labor.
Correct. So you are very right that yes, Dr. Devishi, we missed you for the answer, but you can add your inputs. Please unmute yourself. Unmute, please. Click on the mic.
Okay.
Yeah.
Good evening, ma'am. Good evening.
Good evening. Yeah. So we were talking about the long-term tocolysis, whether it is indicated in a case of preterm labor. For how long we should give tocolysis? I think you missed the discussion. For how long we should give the tocolytics?
Ma'am, till pulmonary maturity, if the steroid dose is done and the magnesium sulfate for 24 hours. If the purpose is served, then we can go on for the delivery, ma'am. There is no role of any long-term tocolysis, ma'am.
Okay, but then 32 weeks, suppose you can stop the uterine contractions, your patient is stable, comfortable, and the pregnant, there is no leaking.
Yeah, then
going ahead, then there comes the role of the progesterone.
Yes, ma'am. If there is no
said, either it can be oral dydrogesterone or it can be vaginal natural micronized progesterone. Okay, so we should try to take this pregnancy to at least 34 weeks, though some of the recommendations say 36 weeks. Okay, so this is how the evolution of management of preterm labor has happened. Initially, see, in the 60s, it was only the hydration, opiate annulation, even IV alcohol they have mentioned. In 70s, it was isoxsuprine and ritodrine, which I'm sure the obstetrician of my generation, all of us have used isoxsuprine and ritodrine day in and day out. And of course, 80s, you have beta-2 agonists, salbutamol and terbutaline, Maxulf and indomethacin. And 90s, of course, there was a reappraisal of the beta-2 agonist. There was a concern raised for the pulmonary edema because of the long-term tocolysis, and then gradual drift away from the beta-2 agonist towards nifedipine and atosiban. So in today's scenario, we would say nifedipine is the drug of choice. And of course, considering the cost efficacy, we can go, those who can afford it, when you really have, we are coming to the discussion, I need not disclose on this. We are coming to such a case that where you can, use atosiban. So we have this second case now.
Madam, before we go to the second case, there is a question regarding the dosage of magnesium sulfate.
Yes. Can we throw some light? I would say the steroids we have already discussed. I would ask all the panelists, not the expert, panelists. Experts' opinion, we will have last opinion. Okay. So the panel, yes, Dr. Sushma.
We have to give it 4 milligrams in 100 ml NS.
4 grams.
4 grams. 4 grams loading dose.
Okay.
4 grams loading dose initially. Then we have to give it 1 gram per hour to continue till 24 hours.
24 hours.
Or for till delivery, whichever is late. I mean, whichever is earliest.
No, that is for, okay, the way you are saying it is like eclampsia, the delivery or the conversion, whichever is last. But then I would tell you, I would ask you in details, how do you give that 4 gram when you are giving intravenous?
4 grams, 4 ampules.
How many ampules? What is the percentage? How is it available? Because that is why the question is asked. What is
preloaded magnesium also is available like pre-mag.
Yeah, okay.
But routinely we use only directly ampules, 4 ampules magnesium sulfate. We can either take it in a 20 cc syringe. So it will come to, and the remaining 8 ml because it is a 2 ml per
Correct. So it is a 50% weight by volume solution, and you have 50% that is
so the
1
remaining
ampule 2 ml, that is 1 gram. 1 ampule is 1 gram. Okay. So 4 ampules are 4 grams.
Yes.
That is
So
8 ml. So
8
this 8 ml you dilute in 12 ml of
12
normal.
ml.
That becomes 20, and then you give slowly over almost
15 minutes.
Yes. So 1 gram per hour, how we used to give till now? Can somebody throw some light on this? It is like a Zuspans regime, what we used to use previously, right?
Even now it is only recommended, no ma'am. Is there any change?
No, there is no change. The only change here is the facilities, better facilities are available. Previously, the regime is same, 4 gram loading dose, 1 gram per hour as maintenance dose. Okay. So previously we used to add 5 ampules in 500 ml saline. Correct. So 1 gram per hour used to come 100 ml of the saline per hour. But there are some patients like you have patients of severe hypertension, waterlogging, eclampsia. So for them, it is to be a fluid overload, right? So that is why to cut short the fluid intake, the preparations are available as 100 ml. So that in spite of giving 100 ml per hour, we now have 100 ml total with 4 grams. So that is 25 ml per hour. Did you get that?
Yes.
Did you get that? 100 ml has 4 grams. So 25 ml per hour, that is 1 gram per hour. So you achieve the fluid restriction by this. Okay.
Ma'am, I would like to add another point about this MGSP4, ma'am. Actually, ma'am have said correctly that we should continue till 24 hours or up to delivery. So now our case is a threatened preterm. But within this time, if she progresses into preterm labor, we need to stop this MGSP4, ma'am. Or after stopping, if she does not deliver till 6 hours, again we should restart the MGSP4, ma'am. This is a recent ACOG.
If she is progressing, otherwise if the labor stops, we need not repeat the dosage. Okay. So now we come to the second case. Now we have few interesting cases here. So here you have this 38-year-old gravida 3 para 2 with 26 weeks of gestation, 2 previous normal deliveries, and now she has polyhydramnios with AFI 17, and she has diabetes mellitus. Now she comes to you with mild abdominal pain. Again here, remember for the first case what we have talked about, the the pain. the characteristic of the pain. So the vitals are stable, and her clinical examination, abdominal examination shows uterus is 28 to 30 week size, and she's getting contractions every 2 contractions every 10 minutes, and each contraction lasting for 15 to 20 seconds. Fetal heart is good. Dilatation is 2 centimeters, 60% effaced, membrane suppression is high. What is your diagnosis here, and how would you go ahead with the management of this patient? For Dr. V. Sarada. Dr. V. Sarada.
Yes, ma'am.
Yes, please go ahead.
Yes, ma'am. What are the risk factors for this preterm? She's a third gravida, 26 weeks, and now she's having pain abdomen. And her clinical features as well as her per abdomen and per vaginal findings show that she's having dilatation of about 2 centimeters and about 50% effacement, 50% effaced.
Yeah, but did you see her contractions are?
Yes.
2 contractions
Are 2 contractions. Yes. To establish as a preterm labor, she should have at least 4 contractions in 20 minutes or 8 contractions in 60 minutes. But she's having 2 contractions. She's having a sort of threatened preterm. And because she's a multi, that little bit of effacement, dilatation, of course, 2 centimeters is showing that she's going to go for a threatened preterm labor. So now we have to assess the risk factor. What are the risk factors for this patient? Like she is going to go for a threatened preterm. We have to take a proper history. And in that history, she's already having 2 preterm deliveries.
No, we haven't said preterm delivery.
No, 2 previous preterm deliveries. But now in this pregnancy, she's having polyhydramnios, which is one of the risk factor for preterm labor. Because of the stretch, polyhydramnios patient is at risk for preterm delivery. So now let us discuss what are all the risk factors actually for preterm labor. In extremes of age, the younger age and the elderly women. These 2 are extremes of age are at risk for threatened preterm labor. Next, coming to socio-economic status, the poor are always affected because of their hygiene. Next, coming to occupation. Suppose if the mother is a working lady.
We're not talking in general. We're talking about this patient only, that she's a multi-gravida, and she's got diabetes and she's got polyhydramnios. So
in this patient, the risk factors are diabetes, polyhydramnios, multigravida, and already she's having contractions, and her cervix is 2 centimeters dilated, and there is effacement also of about 50 to 60%.
Right.
So,
but she's only 26 weeks. So what is the age of viability? Up to what age at least you want to take her up, pull her on?
At least above 32 weeks we can take her, ma'am, because now she's
ideally 20. It is 34 weeks, right?
Ideally is 34
weeks, but by the time you are doing all your preparation, giving steroids and magnesium sulfate, right? So these are all the risk factors for this patient.
If we can take her to 34 weeks, it would be well and good, because she is only 26 weeks right now.
Right. Okay. So these are the risk factors what you were talking about. That
yes.
Yeah. So you can just say, you can just read it out, or you can just talk about all this.
Less than 18 and more than 35, which I told it is extremes of ages. Yes. And if it is an assisted reproduction technique, she is at risk for preterm. And fetal fibronectin. Now, fetal fibronectin is one, it is a glycoprotein, which is seen in the cervicovaginal secretions. Normally, it is seen till 22 weeks, but if it is seen above 22 weeks, somewhere between 22 to 34 weeks, if you find fetal fibronectin positive, that means she is going to go into a preterm labor in the next 1 week. So it is a very important investigation which we can find out if we have the facility. In our town, we don't have the facility of detecting fetal fibronectin in the vaginal secretions. So if there is the facility, then it is a very good, it has very good sensitive and a very good negative predictive value also. If the fibronectin is negative, that means she is not going to go into threatened preterm labor above 95%. Cigarette smoking and maternal habits like alcohol, smoking, etc. are high risk for preterm delivery. Short cervical length. Now on ultrasound, if you find a short cervical length that is less than 25 millimeters, 2.5 centimeters, then she is at risk for preterm. And if there is an opening of the internal os also, like normally the internal os, it is closed and it is T-shaped. If it is going into YUV, then that means the internal os is getting dilated and there is incompetence in the cervix, and that type of patient is at risk of going into preterm labor.
Okay.
High stress in the mother is already known. Just now we discussed about the corticosteroid
Infections
level.
of all sorts.
Yes. And genital and urinary tract infections. They play a very important role in preterm labor. If we take a high vaginal swab and we can detect the group B streptococci, it's well and good that we can start treating her with macrolide antibiotics, and so that we can prevent preterm labor. But only actually preterm labor, we don't treat it with antibiotics unless we find a high vaginal swab positive. There is no need to treat the patient with antibiotics only for preterm labor.
Multifetal gestation, I'm sure all of you will agree to me that, they are always high risk for preterm labor.
Preterm labor.
But whenever you have a patient who, usually right from the beginning, she gives you history of spotting, early pregnancy, hemorrhage, maybe
Yes.
chorionic, that is the one
That
who
is the
high
patient
risk
who is
for preterm labor. Of course, patients who are, either not coming regularly for the antenatal care or maybe coming very late, second trimester onwards, they are the one. In addition to the uterine anomalies and acute conditions, of course, the surgical procedure of the cervix conization, etc. All of you know that for the kids, post for the kids.
And surgical procedures on the cervix also. If there is a history of conization, then she's at risk for preterm labor because of the incompetency of the cervix.
Okay, so most
So
important risk
clinical
factor
factors.
is history of prior preterm birth. Okay,
Yes.
most important is history of prior preterm birth.
History is very important. If she's having a history of prior preterm, we have to definitely take care that she is at risk for preterm.
Yes. So, Dr. Manjushree, we have, this patient already, we have already discussed about this, that she's a diabetic patient, multigravida, 26 weeks pregnancy with polyhydramnios. And you do have uterine contractions, which are quite regular every 5 minutes, 2 contractions in 10 minutes lasting for 20-25 seconds almost. And of course, she has some cervical changes of dilatation and effacement. So what is your plan for this patient? How do you go ahead? Whether you want to conserve? If yes, how? If no, how?
Yes, this patient is in the preterm labor, ma'am. So I would admit the patient for continuous monitoring. Continuous monitoring for contractions and also the fetal heart rate. And I would start the tocolysis. My drug medicine of choice would be nifedipine, a calcium channel blocker. So, and also start simultaneously corticosteroids, betamethasone or dexamethasone for the lung maturity to reduce the risk of respiratory distress, and also magnesium sulfate for neuroprotection. As we have discussed the same dose. And when I have started the steroids, as the mother is the diabetic, I would check for the sugar levels also, and accordingly optimize the drugs, either the insulin levels, and accordingly. And antibiotics, if there is only any suspicion of infection, not a prophylactically. And also, I would get a neonatologist consultation if there is any potential preterm delivery and the NICU stay.
What medical treatment you will carry out for this patient? I think that is the only thing which you need to elaborate. I think everything you have covered. Medical treatment in the sense, considering her diabetes, you said steroids. So for steroids, what precaution you want to take, whether you'd like to hospitalize her, what counseling you want to do, whether you will explain her that the sugar levels may go. I think Dr. Bharati can throw some light on this.
Yeah, thank you, Dr. Sneha. Well, Dr. Manjushri has elaborated, but one more point is I think we'll have to counsel the mother and the relatives that when we are going to give her the steroids for lung maturity, I would prefer dexamethasone. But even that, there may be a marginal increase in her hyperglycemic status. So probably, as Dr. Manjushri mentioned, the insulin dose may have to be increased marginally, maybe 4 units to 6 units. We'll have to keep the hyperglycemia under control. And another thing that I would like to do, her urine culture and rule out asymptomatic, and urine examination and rule out any asymptomatic bacteremia, and her CRP and her counts. So if she has infection and she's a diabetic and she's going to get a dose of steroids, so probably if she has any signs of infection, we will have to use an antibiotic, either erythromycin or ampicillin you can use, 500 milligrams 4th-hourly, but do not use amoxiclav. If they are sensitive to any of the penicillin drugs, you can go for azithromycin. That is one point. And the other thing is, when you are starting them on tocolysis, you're giving her nifedipine as well as you're giving her magnesium sulfate, we have to be a little cautious because we are using two tocolytic agents, and there may be some upsets in her hyperglycemic status as well as her reflexes. So we have to be cautious and monitor her reflexes when you're giving magnesium sulfate, and ask her to, of course, we're going to do the NST, we're going to do the fetal monitoring. And of course, you may get, if you have an option of a dietitian, or you can always do the dietary consultation and tell them to see that their sugars are well controlled, and ask her to keep a very close monitoring of the fetal kick count. Because the maternal fetal kick count can also, because when we give steroids, sometimes there is a decreased fetal movements are observed, and that along with her diabetes, we have to be very careful because the sudden rise in sugars can also affect the fetal morbidity.
Right.
The progesterones, yes, we will start progesterones. Probably we can also start her on progesterones, so that we will continue that following what short-term tocolysis we're going to give her. And once the contractions stop, we will stop the nifedipine or what for 20 after 24 hours, and
go ahead with
progesterone. So you can start the progesterone as you start the nifedipine itself.
Yes. Very well sum up, Dr. Bharti. I would just add one or two things. First and foremost, because she is diabetic and already she has faced the preterm labor, we have to keep a watch on her local hygiene, which she has to really, because if she has glycosuria, then definitely she's very, very prone for the local vaginal infection, which will make her prone for the rupture of membranes. So that you have to really take care of. And as you said, that you can start her on antibiotics if at all she has infection, right? So that you have to study for that. You have to really send her midstream urine sample and also the high vaginal swab to rule out any local infections. Then only you should start antibiotic. Secondly, steroids, it's not a contraindication in diabetic. Some of the patients, some of our obstetricians, they still have the misconception that because she is diabetic and it may raise her blood sugar level, so you should not give. I would just remind you that, in patients of diabetes mellitus, these are the very women where the, baby's lung maturity is delayed. And in spite of near term also, what we label it as late preterm, the babies land up into what we call it as RDS, okay, in spite of being near term. And that is the very reason we should insist on giving these steroids. Only we should hospitalize them, monitor these sugar levels quite stringently, and adjust the dose of insulin if at all she is on. That is how. And of course, as Dr. Bharti has said, there is a little clarification that, magnesium sulfate and nifedipine, again, there it is not to be given simultaneously. No, you have to just keep a watch. As she has said it, you have to be very vigilant, but you can give it together because that is a need of the hour. Okay, so the management, of course, all of you have said it that, if at all she is having the uterine contractions, you give her tocolytics. Meanwhile, you give her steroids, give her magnesium sulfate. Of course, you stabilize her sugars also. Communicate with the multidisciplinary team. If at all you have a good NICU and a multidisciplinary team, no need to transfer her in utero. But if at all you don't have, then you need to transfer her in utero. Discuss the plan with the patient, with the relatives, maintain all the documents necessary, and then of course you have to reassess once you are giving her the treatment, maybe over a period of 12 hours, 24 hours, you have to reassess whether she is really responding to your treatment. This we have already covered, so I'm going to skip this. Now, what is the rationale of this tocolysis? We have already covered for the first case, so I'm not going to discuss this again.
Madam, one question. One question regarding steroids, madam.
Yeah.
If now she is 26 weeks and she is going to continue. Suppose she is going to continue her pregnancy.
I was expecting this question. Whether she needs a rescue dosage. Yeah.
Repeated steroid.
Yeah. So what IAP has come up with the guidelines and, extensive study and multiple RCTs and everything, they have come up to a conclusion, or I would say a recommendation, that there is absolutely no need for giving the rescue steroids. They say that in fact it is detrimental to the fetus giving repeated dosage of the steroids. It leads to cerebromalacia. That is what is the observation and of course the correlation. So IAP strictly, pediatricians strictly advise you against giving the rescue dosage of steroids. So one single schedule will lead to lung maturity, and if at all she doesn't deliver during that particular week or so, you need not give her rescue steroid dosage. That is what is the recommendation. Okay. What is your observation? What is your recommendation for the tocolytics? Which one you should prefer the best? Who will take up this? I think Dr. Devisri and Satyashilpa.
We prefer nifedipine, ma'am, and magnesium sulfate is in this case magnesium sulfate will help, ma'am. Both neuroprotection and this.
Yeah, it will act synergistically. It will act synergistically with the whatever tocolytics you are giving. So it will do dual job. Correct. So beta agonist, are you using?
No, ma'am.
Duodenum, isoxsuprine?
No, ma'am.
No, ma'am.
Not using. Yes, but can be used. Huh?
Can be used.
Don't be totally against it. That is what I want to say. See, short-term isoxsuprine is not a toxin, okay? Short-term, if I tell you that if we share our experiences, we have used isoxsuprine for months together. Okay. Let me confess. Maybe because it was never studied and never, even then, we have never experienced any such problems like pulmonary edema in any of our patients. But when your parent body or your parent organization says that it is not recommended, we better stop using it as a long-term tocolysis, correct?
Yes,
so that, if something goes wrong, the recommendations will not protect it. In fact, it will go against us, correct? And that's a very reason. But short-term tocolysis with isoxsuprine, with ritodrine even, is recommended and accepted and very cost-effective. Okay. Because this patient really had regular contractions every 2 to 3 minutes she's having contractions. We really need to stop those contractions first. So if at all she is not good socioeconomically and then she can't afford atosiban, then what will you do? You have to go ahead with the isoxsuprine. Sometimes, even today the obstetrician at some of the places, they're very scared using nifedipine. Let me share with you that they are not very comfortable using. They feel that it's an antihypertensive. If you give the tablet nifedipine, the patient's blood pressure will fall. So that is how we have to convince them that it has been proven beyond doubt that therapeutic dosage of nifedipine when used for tocolysis, they are safe and effective. Correct? But if at all you are not comfortable, maybe you use it under somebody's guidance, or maybe you use whatever tocolytics available, what you are comfortable with, and that is why the role of
wanted to say something.
Please go ahead.
Bharati madam.
Yes, madam, Dr. Sneha, I would like to tell you that yes, as you said, isoxsuprine has been a very safe drug. We have all been using it, and now various studies have again bringing it back. Isoxsuprine is again coming back like what we used to use, and as you rightly said, that is a good alternative, especially when we are comfortable with that drug. And the only problem we used to have is maybe tachycardia or headache. Otherwise, isoxaprine was a very safe drug, and many reports recent. Yesterday, we had a panel on preterm labor, and we discussed the same point. And isoxaprine is making a comeback.
Yes.
Madam, and regarding dosage of nifedipine, there is a question.
Yes.
Can you please elaborate?
Yes, Dr. Bharti, you can take up that question.
Yes. So the dosage of nifedipine is you use the nifedipine tablet, 30 milligrams stat, and then you continue with 20 milligrams for 20 milligrams, I think 4th hourly for 24 hours.
Yes, we have been using 20 milligram. That is also one more recommendation, 20 milligram, and to be repeated at 4 hourly or 6 hourly, then gradually you taper it down, and then you maintain the patient on progesterone. That is what.
Even
Now
we are using 20 milligrams only.
Yes, 20 milligrams.
20 milligrams.
Yes.
Use 30 milligrams stat, and then we change to 20 milligrams 4th hourly for 24 hours.
And close monitoring. The action will start from half an hour.
Half
Half an hour.
Always admit the patient and give it as an inpatient and hydrate her adequately. That's
Yes.
important.
Yes, hydration of the patient is important actually.
Right. So you have all sorts of, tocolytics available. There's no evidence for prophylactic use. Once the contractions have ceased, don't use tocolytics. In fact, you maintain her on progesterone, which is only the uterine quiescent. Okay, it makes the uterus quiescent. So now that if your patient is affording and you are really worried that maybe this tocolytics will not help, then of course you have a better choice. So Dr. Sri Devi, can you please talk about the atosiban? If you keep on your videos on, I think it will be good for me to invite all of you for the questions. Sometimes I'm not able to see all of you. Dr. Sri Devi, please.
Madam, Dr. Devi Sri.
No, Sri Devi has raised her hand. That is what the notification.
Yeah, Madam. Bharti Madam has answered that question, Madam.
Okay, go, no problem. But she's a panelist with us.
No, Madam. Our Vijayawada President Dr. Sri Devi raised a question and Bharti Madam has answered.
Okay, correct. So, can somebody take up this question? The schedule for atosiban. I think Dr. Sushma.
Yes, ma'am. Atosiban is a oxytocin antagonist, oxytocin receptor antagonist. So it directly acts on the mechanism of action is very clear. Hence, it is the preferred drug. But in India, I think because of cost constraints, we are not using it much. The dose is 6.75 mg stat dose, and then followed by 70 mg. We give it that is 2 ampules. One vial comes as 37.5 mg. So that costs 5,000, and we can take 2 vials of that. That comes to around 70 mg. So that one we have to give it slowly over a period of half an hour to 1 hour. So stat dose is 6.75 mg.
Right, that is what it is. You can see this. These are the bolus is 6.75 milligram given over 1 minute, and then the IV loading infusion. You give the infusion for 3 hours. That is 300 microgram per minute. Okay, and then next you continue. So after the first 3 hours, you're pretty sure that now the contractions are minimized. Then you maintain her on 100 microgram per minute. That is the infusion rate, up to 45 hours almost, so that you are sure that she will not go into the preterm labor again. Okay, so what are the contraindications for tocolysis?
Chorioamnionitis.
Dr. Devashree. Dr. Devashree.
Ma'am, if there is an IUD.
Yes.
And if the preterm labor is inevitable, if there is any anomalies for the fetus, if like delivering is better than
fetal death and fetal anomalies, lethal fetal anomalies.
Yeah. And any infections, just like what Sushma has mentioned, any chorioamnionitis.
Right. And one more point while discussing, we said that if the fetus is already compromised, there's non-reassuring fetal status, then why do we want to continue? It will result in IUFT, right? Preterm PROM, actually you should not give tocolytics. If at all it is going to continue on its own, so you buy some time till you give, rescue steroids and your magnesium sulfate, and you take care of it. But let me explain you that, or let me share with you, I have almost 25 to 30 patients whom we could continue beyond 2 months. So, that is how but it was without tocolytics, absolutely no tocolytics. Okay.
Yes, madam. As long as there is no infection, we can continue for months.
Yes. And chorioamnionitis is the only indication worsening maternal status for this. Okay, so we have already discussed this. So Sushma, we will skip this. I think you only have answered this. What is the schedule for neuroprotection, magnesium sulfate? We have already discussed this in detail. Somebody has asked me the question, but NICE guideline 2015, and all of us are routinely using this now. Okay, so we have already covered all this. Now, what are the problems in preterm baby and what care should be offered? Dr. Satyashilpa, even though we are obstetricians, we are not neonatologists, but all of us should know this so that we can keep a watch on this, we can be vigilant about this, and we can be proactive talking to our neonatologist.
Yes, ma'am. These preterm infants, because they are immature, there will be multiple problems like respiratory distress after birth.
The immediate one, yes.
Yes, ma'am, the immediate one. So immediately after birth, we should check if the baby is crying or not, if the baby is breathing or not. And we should call the neonatologist beforehand if we are planning for a delivery. And if the baby is breathing and if she is fine and she is crying, we can immediately transfer the baby over the mother's chest so that it will prevent hypothermia, ma'am. So coming to next problems, after respiratory distress syndrome, the baby may have cardiac problems, ma'am, because of patent ductus arteriosus.
Right. But before that, you said RDS, respiratory distress syndrome. You said hypothermia.
Apnea. Yes,
what about hypoglycemia, hypocalcemia?
Yes, ma'am. The baby will have this hypoglycemia and hypocalcemia also, ma'am. And I'm coming like a system wise, ma'am. That's why I could not cover that hypoglycemia and hypothermia, ma'am. So after checking this respiratory system, we'll check for the we'll maintain the temperature. We'll shift the baby to NICU, ma'am.
Right.
Coming to this hypoglycemia, we'll take the blood samples and we'll check the hypoglycemia because it's a preterm baby. And coming to CNS.
What other problems? You have said about RDS, hypothermia, hypoglycemia, hypocalcemia. Because you are, this preterm baby, what all systems are getting involved, no?
Yes, ma'am. Nervous system will be involved, ma'am.
Yeah, don't try to feed this baby at the earliest. This baby has a very vulnerable necrotizing enterocolitis.
And reflux also will be there. This esophageal reflux will be there, ma'am. So we'll be using a feeding tube for that baby. And coming to CMS, it may have intraventricular hemorrhages or venous thrombosis also, ma'am.
Because you are giving, as you rightly pointed out, the patent ductus arteriosus, persistent fetal circulation will also be there. Because this baby, you are worried about the hypoxia, you're giving her the baby hyperbaric oxygen, and this is the baby, which is going for the retrolental fibroplasia and permanent blindness, and the patient will sue you. You save the baby and the patient will sue you for the blindness. Okay, so that is how it is. So whenever you are the first, now we go back that first and foremost, whenever you are trying to conserve this pregnancy, you discuss with the relatives that if at all we try to conserve this baby, and if you try to delay this delivery, it may reduce these complications. But if at all she lands up into spontaneous preterm labor, which she has already in, then the babies will have these complications which we cannot prevent. Whatever precautions you take, we are trying to do our best because we are trying to prepare the baby. Okay, we are trying to prepare the baby also, we are trying to conserve the pregnancy also, but we have to weigh the risk and benefits, and that is why the informed written consent has to be taken from the patient and relatives, saying that even if we deliver the baby in good condition, because of the preterm or the prematurity of the baby per se, the baby's systems can get affected and will manifest later in, over the period of first 3 to 5 days, or maybe even 1 or 2 weeks. That is what we have to explain them, and you take the informed written consent. Otherwise, for that blindness of the baby, you may be blamed. Okay.
Yes.
The neonatologist, of course. So obstetrician and neonatologist, you will have to sail through the same boat. Okay. So this
And
is.
I'd like to counsel them, ma'am.
Yes.
Because till 5 years, the baby is at risk because of this prematurity, ma'am.
Right.
It may get seizures or like cerebral palsy, or the most commonly this within 5 years deaths are also due to preterm only.
Okay.
So I would like to counsel them for long-term effects also, ma'am.
Yes, and once if at all this baby comes out from these acute complications, the baby can land up into what is called as the exaggerated physiological, or may even be the pathological jaundice, and the baby can land up into kernicterus and all these complications, right? So everything has to be explained beforehand, not when the baby arrives. Okay. At the moment you see that you have a patient of preterm labor, I think you start talking to them slowly, one by one point, and you make them feel and understand and take it in writing, the informed written consent, right? So we take, I think, one more case, only the last now. Dr. S.K. Shilpa. Yes, please unmute yourself. We have this 28-year-old primary gravida conceived with IVF, and now she has twin gestation, 29 weeks. Okay, she presented to you with labor pains. That means she's in preterm labor. Vitals are good. Uterus 28 to 30 weeks size, head floating. Contractions, 3 contractions in 10 minutes, each one lasting for 25 seconds.
She's in early labor.
3 centimeters
She's
dilated.
established.
Yeah, hello, can you hear me? 3 centimeters
Yes, ma'am.
dilated, 60% effaced. So what is your diagnosis first? Any role of cerclage here at this point of time? Yeah.
She's in established early preterm labor, madam.
Right.
And regarding rescue cerclage, emergency cerclage, contraindications are if there are uterine contractions are there, or if there is bleeding is there, then it is contraindicated. So she
you
already
have to
has
say very firmly that absolute no for this cerclage.
no cerclage
But
for
she
this.
actually has very strong contractions, 3 contractions in 10 minutes, each lasting for 25 seconds. So first and foremost, your aim should be to stop
with
the
uterine
contraction.
contractions.
Right. Now you tell me which tocolytic you will prefer here.
Tocolytics are contraindicated in twins. Not recommended.
Why? Not really. In fact, we want to take them ahead. No, my dear. Why do we want to deliver her? And what is the reason?
More chances of complications in her.
Yeah, but 2 to 3 days tocolysis will not
Yeah,
lead to complications.
only till the steroid coverage.
Yeah, that's what we said. Not long-term tocolysis. It is only short-term tocolysis. All of us have accepted. We all have accepted to the consensus that yes, short-term tocolysis for maybe 2 to 3 days should be good enough, right? So, but now this patient has really good contractions. I mean, I would say not good, bad contractions, strong contractions. Okay. So here I think it is, because it's a IVF pregnancy. Okay. So IVF pregnancy, twins, strong contractions. So definitely atosiban here. Okay. Right. The patient is affording also. All of you know that she has gone for IVF. So, and of course, twin babies, if at all you lose, you're going to lose 2 babies. So definitely you try your best to go for atosiban. You give her a complete regime of atosiban, maybe 45 to 48 hours. By the time your steroids, your magnesium sulfate should act. And then if at all you find that there is now absolutely no uterine contractions, because once the contractions stop, even the pressure in the intraamniotic pressure goes down, and the pressure on the cervix goes down, and maybe sometimes you find the cervix starts closing, correct? Now here, this patient you can maintain on the vaginal progesterone. Maybe you can pull on to some extent, right? But absolutely no role for cerclage here, because cerclage will again prick through the cervix and initiate uterine contractions, right? I'm sure all of you know about what is Ferguson reflex. Once you touch the cervix, the contractions get initiated once again, and that is a reason you will not go for cerclage, correct? If the uterus is absolutely relaxed and you find the totally painless dilatation, I think that is a time where you can, that is a case where you can go for the rescue cerclage. But here it is again 29 weeks. Okay, so you have to go ahead for at least 4 to 5 weeks, if at all. So for 4 weeks or maybe 2 to 3 weeks, I don't think you should go for cerclage. But then definitely try and conserve this pregnancy. Though, just for your information, if at all anybody can take up the procedure for rescue cerclage, that will be good enough. Who will take up the cerclage? Okay, so this is an individualized procedure. I have also done very few, I think 3 or 4, not many. And out of 4, almost 2 to 3, I remember they were good, but 2 I could not sustain them. So it is an individualized procedure, and you have to make sure that the uterus is absolutely relaxed. The intraamniotic pressure is not very high. Yes, Dr. Bharti, you want to say something? Dr. Bharti?
No, Sneha, please continue. I'll talk later.
Yeah, so you have to go ahead with this procedure very, very carefully. You have to give the routine sepsis, antisepsis, everything has to be followed. You have to, catch hold of the cervix very gently, preferably with the sponge holding forceps as far as possible, not to disturb the membranes. With the help of the gauze piece or a swab on this, definitely you have to gently push the membranes above. See that you don't rupture the membranes, or maybe you just put in a Foley's catheter, inflate the balloon so that the membranes go high up, and around these Foley's you can go ahead with the cerclage. And after you complete the cerclage, just before tying the knot, you deflate the balloon and gently you remove the Foley's catheter. That is how it is done. I mean, I'm afraid I won't say dogmatically that it is very, very effective. Even with the expert hands, it can, land up into failures. Now that, you are monitoring this fetus, you are trying to conserve this pregnancy. How do you make out the what you say, the fetal well-being? What is the difference in monitoring the fetal well-being in a term fetus and a preterm fetus? I would ask Dr. Sushma, Sarada. Yes.
In term fetus, accelerations are more than 15.
Yes.
Increase in heart rate of more than 15, lasting for 15 seconds.
Mm-hmm.
Whereas in preterm fetus, the baseline increases by more than 10 beats, lasting for only 10 seconds.
Right. So that is how you have to, otherwise you will feel that the acceleration is not adequate. That means the fetus is not responding well to the stress, correct? So that is not, you have to know what is the reactivity of the preterm fetus. I think, should we go ahead with this case or should we stop here? Yes, I would ask the panelists, or we just, I will just have this case, this is what somebody was talking about, the Arabian cervical pessary, and Dr. Sushila, madam, she was saying that Lancet 2013 has also come up with this study that the Arabian pessary reduced the preterm birth in an open label study of women with short cervix, that is less than 25 millimeter. But it is not recommended even today. In India also, there were few centers who has conducted, including Dr. Malhotra Center at Agra, but the results are not very promising, and that is the very reason it has not come into the routine practice. That is what we can say. I will just take this last case. We have this primi gravida conceived after 7 IVF failures. Now she's 24 weeks. She came to you in the casualty with complaints of leaking PV. Primi, 7 IVF failures. Now she conceived with 8th IVF cycle and 24 weeks gestation with preterm PR1. Vitals are good. Uterus only 22 weeks. Okay. Regular fetal heart, leaking plus. Who will take this case? How to manage this patient? 22 weeks only. Please unmute. Please unmute.
On per-abdomen examination, can you feel the uterine contractions, ma'am?
No.
Only leak is there. So, as usual,
I said it is different. Now it doesn't require tocolysis.
Yes, ma'am. We can give corticosteroids, ma'am.
Yeah. Tell me how to manage.
First, we would admit this.
Myself, yes.
We
We'll
would
admit
admit this patient,
sure.
observe if there is any, we'll confirm there is any leaking first, ma'am.
Yes. Yeah, because it is her
Yeah,
complaint.
and
You're
we'll,
right. So I have given you the finding that per speculum
Yeah.
examination says yes, leaking plus. Okay. Now
and
you tell me how do you go ahead?
we'll do
Whether you
a
would like to
ultrasound.
conserve her, or whether you would like to go ahead with active termination, or whether you would just wait and watch.
We'll conserve. We'll wait and watch.
Conservative, we'll wait and watch, ma'am.
Okay. How do you do that?
Wait for any chorioamnionitis, wait for any progress of labor, and it has to be handled in a tertiary care center.
I
with
won't
good
say wait
NSU
for
facility.
chorioamnionitis. I would say try to prevent chorioamnionitis.
Prevent.
We'll send a high vaginal swab, ma'am.
Watch
And
for
detect at the earliest. Right.
High
So
vaginal
how do
swab.
you prevent that? Dr. Manjushri.
Antibiotics, I would start, ma'am.
Which one?
Erythromycin,
Yes.
250 QID.
Right. Suppose not erythromycin, you don't have that. Then which one? Azithromycin?
Yes, ma'am.
You have it as 1 gram IV, right?
Yeah.
Yeah. Okay. So you give 1 gram IV azithromycin, and then of course you give it for anaerobic also, you give metronidazole, correct? 22
Yes.
metronidazole is safe, don't worry.
Yes, ma'am.
Okay. Yeah. Then how do you go ahead? You do her
Serial
ultrasound.
ultrasound monitoring, serial total counts monitoring.
You
Then
monitor
what?
the mother, monitor the fetus, like you do it
Yeah.
for even otherwise also you do it.
But then, ma'am, at 24 weeks, Liker is only 2 centimeters.
That is the
26
largest
weeks,
That is single
pocket.
largest
That is the
pocket.
single largest
Largest
pocket
pocket.
measurement. That is a
So
different.
single largest pocket of
It's
2
not
centimeters
AFI.
is adequate, ma'am.
Right. It is
Single largest
actually
pocket
8.
2 centimeters is adequate.
Before 27 weeks for lung maturation, Liker is very important.
Right.
After 27 weeks, Liker might not play a role, but before 27 weeks for lung
Yeah,
maturation.
but this is
very important.
Liker adequate. By meaning this largest pocket of Liker measuring 2 centimeter, the Liker is adequate. Okay, that is what we want to say. So how will you manage this case? I have already shared with you that I have almost 30 patients which after complaining of leaking and actually demonstrating leaking, we could continue up to almost 2 months or so. Without any sucklage, without any tocolytic, just wait and watch the pelvic rest. Okay, pelvic rest, maintain the hygiene, collect the high vaginal swab every weekly if at all she doesn't have clinical signs and symptoms of any infection. If at all you feel that she may develop some infection or maybe early infection, then maybe at the earliest twice a week you can go ahead with the swab. And then of course you ask her to use a sanitary napkins with the antibiotic local metronidazole gel or so. And then meanwhile, you try and conserve this pregnancy. You do the bedside ultrasonography. You find that the, the liquor is maintained good quantity so that, the nutrition and everything, circulation is maintained for the baby. And then maybe up to the salvageability, you can take this. But at least to that period, you can take it maximum possible so that, you have some chance for survival. Otherwise, at 24 weeks, what you have in your hand, you have to lose the baby. Okay. So would you advise tocolysis?
She's not having any active contractions. Also, PP or VM, we are not supposed to use tocolysis.
Correct. Are corticosteroids warranted?
Yes.
Yes, we have already discussed. Would you use antibiotics for this patient, and what is the rationale for your choice? We already said erythromycin, but if not available or not comfortable, you can use azithromycin. And is there a place for antibiotics in a woman presenting with preterm PROM? That we have already discussed. What is the current international guidelines now? This is on using the progesterone. So European Association of Perinatal Medicine 2017, Western Australia Preterm Prevention Key Initiative, French Clinical Practice Guidelines 2016, NICE Guidelines 2015, FIGO 2015, START-OG by RCOG 2014, ACOG 2012, and SOGC. All of them, recommend the use of progesterone in preterm labor, especially when you have the short cervix. And they have, FIGO also endorses that in a mid-trimester singleton pregnancy with a short cervix, the cervical cerclage is and progesterone it has compared. So they are equally efficacious and safe as well. That is what it has been endorsed by FIGO. So this is FIGO guideline international. You can see here it is very clearly mentioned that universal cervical length screening has to be done at around 19 to 23 weeks. And of course, you should use vaginal progesterone. But nowadays they are saying even the oral micronized sustained release preparations which are available, they are also equally efficacious. That is what it is suggested. And this is the practice recommendations, STRAT-OG, RCOG, SCOG guidelines, SOGC, all of them, they are saying that use of progesterone as an alternative to cervical cerclage in women with previous preterm birth and mid-trimester loss with a short cervix that is less than 2.5 centimeter is recommended. So as Dr. Sushila has already said, only if it is less than 1.5 centimeter, where you have some history of trauma or surgery on the cervix, or whether the patient has had, preterm delivery, prior preterm birth, in spite of using the progesterone in the previous pregnancy, that is an indication for cervical cerclage. So I'm sure all of you are convinced that it is our duty to give a healthy baby to the healthy mother, and it should be an emotionally fulfilling experience, not that small 600-gram baby going to NICU, going through all the complications, and the parents are also going through all the stress, financial as well as emotional stress, and the baby is ultimately not with intact survival. So I think our aim should be to give the healthy baby to the healthy mother with intact survival. That is what our aim should be. And with this, I thank all of you. And I just take this opportunity humbly to seek your blessings.
About the
Yeah, we will cover that. I'll just complete my appeal first, that I take this opportunity to seek all of your blessings and best wishes, and of course the votes during 1st to 10th August when the elections are happening for this election this year. I request you to support my candidature as Foxy Vice President from West Zone. If you feel I deserve, please do support and vote for me. Thank you so much. Once again, I thank everyone here. Thank you so much.
Neha, there are a few questions.
Yes, please go ahead.
One is Dr. Chaya wants to know, is amnio infusion recommended?
I think that is always a debate here. It is not at all a simple answer, and there is no recommendation. And I'm sure all of us have become wise enough not to even accept the recommendations. So there are so many recommendations saying that yes, if you really have very less of amniotic fluid, and you want to conserve the pregnancy, take this pregnancy ahead, you may go ahead with amnio infusion. But even when you have near-term pregnancy, just because of the fetal jeopardy, if at all you are suspecting, for that also, if you go for amnio infusion, I think people claim for the introduction of infections and maybe trauma to the placenta, RHM, if at all sensitization, so many issues are raised. So I think it's a question mark even today. So naturally, if it is a pregnancy of a very, very early pregnancy or early preterm labor, what we are discussing 24 to 26 and 28 weeks, there it is definitely a question. But amnio infusion, I don't think, I am not practicing and I have no experience. I have done few of the amnio infusions, only me and Dr. Girija, we were together. We have done it as a resident during our PG days. And after that, since last 32, 33 years, I have not practiced it even in my private practice. So if anybody has an experience, in fact, I would be happy to listen to them.
Well, Dr. Sneha, as you said, I also shared the same experience. In the early days of my practice, we have used amnio infusion. One was in this very early preterm with oligomnias with no fetal anomalies. And sometimes in thick meconium stain, fetal heart is reassuring. And those days, as you said, we were trying some amnio infusion. But nowadays, for the past 25 years, I have not used it.
Right.
That's what I would like to say. And there's another question. What about the use of 17-hydroxyprogesterone?
Yeah.
The progesterone supplementation.
Yeah, I think you can talk about it. That's a good.
I think we were using, like, as Dr. Sneha would agree, that when we started our practice and as residents, that was the drug which we did not have Myconos progesterone, and we had just one product of dydrogesterone at that time. We were using 17-hydroxyprogesterone, and now it has made a comeback. And there are a few studies where they say that you could also use the 17-hydroxyprogesterone, but the aqueous injections would be better than the oil-based injections, because they're quite painful, and the incidence of abscess was there, and coming to the hospital and all these implications are there. So it would be a wiser choice to go for a micronized vaginal progesterone or oral progesterone when you have an alternative. If you don't have an alternative, I think then you could go for, if the patient is not compliant, maybe you could go for the injectable. It's not that you should not use it. There are studies saying that they are also beneficial.
Yeah, there are 2 points which I would like to add on to this, what Dr. Bharati said. One is the feminization of the fetus. That is the issue which is raised. And of course, when you talk about these progesterones, you have natural progesterone and you have synthetic progesterone. So 17-hydroxyprogesterone is a synthetic progesterone, and micronized, of course, all of you know, the name itself is natural micronized vaginal progesterone, natural micronized progesterone, which is structurally and biochemically similar to our endogenous progesterone. Right? So its actions are very same. Naturally, natural doesn't make you harm anything. Okay. But the synthetic ones, you have fluid retention, you have alteration in your lipid profile. And of course, the mental, psychological disturbances and other things also. So that is why I think this has taken a seat back. In addition to what Dr. Bharti said, of course, the pricks and the oil-based injections making the large lumps and the abscesses also, that is also one more point. So definitely the micronized natural progesterone, which is now available as aqueous injection, if at all you want, but then they are available as on daily basis. So I won't think that any lady would want to have the daily injections, daily pricks. So best way is to go for natural micronized vaginal progesterone, which I think is evidence-based. So let us come to the consensus that natural micronized vaginal progesterone is the best as far as the preterm labor or RPL is concerned. But the pharma and maybe the technological advances, which we are also talking about, that there is a technological advances where the formulation has been changed to such an extent that it goes into the polymorphic, the complex is there and it is not broken down. Slowly the tablet is eroded, it absorbs moisture and then it releases the progesterone in the lower GIT, and that is why the hepatic bypass is done, and that is why the side effects like giddiness, nausea, the sedation which are there with the oral progesterone, and also the oral progesterone, the absorption, that means the bioavailability is very less. So you need to take larger doses and you need to take it frequently, and that is why these people are coming up with the sustained release preparations. I think that is what is the technical and technological description I can make it. I think as a clinician, we should believe whatever we are practicing, and we are the best judge as far as our clinical experience is concerned. I think all of you are practicing senior experienced obstetricians, so you can take your own call. But natural micronized progesterone, though people again say that, the duphaston, dydrogesterone, these are also the oral progesterone, which are equally effective as far as the immunomodulation and the early pregnancy loss is concerned. So for preterm birth, definitely it is a natural micronized vaginal progesterone. That is what I can say. Thank you.
Dr. Sneha, here I would like to humbly request all of you from Vijayawada, Rajahmundry, Mahbub Nagar and Nalgonda societies to kindly support me and vote for me for the chairperson of Perinatology Committee, and also to support Dr. Sneha for the vice president post. And I thank Dr. Shailaja and all the other societies from Rajahmundry, Nalgonda, Mahbub Nagar, for Vijayawada, for inviting me and giving me an opportunity to be part of this panel. Thank you very much, and it was an excellent discussion.
Thank you very much,
so much. Thank you, Dr. Niharika and Dr. Shailaja. Heartfelt thanks to both of you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Good night, ma'am.
Thank you.
Good night, everybody.
Panel expert, Dr. Bharati, and of course, all my wonderful panelists who have really made this discussion very, very informative. Thank you so much. Thank you, everybody.
Thank you.
Bye-bye.
Thank you, ma'am.
Thank you. Good night.
Bye-bye.
Have a happy weekend.
Thank you,
ma'am.
I'm
Thank you.
traveling to